you so much, our faculty who got it with so much of time difference in various zones. Thank you so much, everyone. To introduce to our Indian Arthroplasty Association members, we are doing the 360-degree webinar series, and today is the 25th webinar, which is organized by our friend, Dr. Abhay Elhins, who has taken a lot of effort. He has tried to rope in many very eminent names from the world, which he will be introducing one by one. We'll be having in this 2-hour session, we'll be discussing the femoral stems in primary and revision total hip arthroplasty. We'll be discussing its biology, metallurgy, and philosophy. Some very important points will be brought in by the eminent faculty, and I'll request Dr. Abhay Elhins to start the proceedings of the meeting. Thank you so much, Abhay.
So we can just let this screen be, sir, while I introduce the first speaker. So thank you very much all. Extremely grateful for all of you to have spared the time and to share your immense wealth of knowledge. And it's a very, very important topic. And while a lot of us are talking on the acetabular side issues as well, the femur side is something that is extremely, extremely important. And there are no clear-cut solutions in a lot of time. The more the bone loss, the more we start wondering as to how do we get to a longevity with a particular reconstruction. So without wasting too much time, again, my sincere gratitude to the faculty, and I will request our first speaker, Mr. Chris Wilson from Adelaide, Australia, to open his talk, the opening batsman. Thanks, Chris.
Thank you. Well, thank you for the introduction, and I'm obviously going to talk about conservative femoral revision, which is a subject very close to my heart. And I heard some of the faculty earlier on talked about trying to make things look like a primary, and I think that's a good way of looking at how we've been trying to move forward recently. So for those of you who don't know me, I'm an Australian-based surgeon, but clearly I don't sound like one, and I trained in Scotland, although also in Australia, and been a specialist in arthroplasty for about 15 years. I specialise in robotic surgery, but also in hip and knee revision surgery, which is clearly why I'm here today. But also one of my other major interests, which is outside the scope of my talk, is arthroplasty infections, and I chair our local MDT department for that. But to focus on what we're talking about today, my specific interest in relation to this talk is obviously for revision hip arthroplasty. And we've done a lot of work in our department about looking at revisions and why hips fail, and also accurate diagnosis about why hips fail, which I think is a key point I'm going to get to in a moment. I have a very strong interest in the technical issues of revision and how we can improve them, but one of my main focuses is really about re-revision surgery. I think that is our biggest problem, and I'm trying to look at how my conservative approach and bone-sparing approaches can help us reduce re-revision surgery. So as we all know, the number of total hips is increasing in Australia and all over the Asia Pacific. This is a widespread problem that's well known, but certainly in our market, about 65% of patients are pretty young, less than 75 years of age. And certainly the amount of hips is increasing in primary hips, and the amount of hips in younger patients is increasing. When we look at our failure rates, approximately 6% of our patients are revised at 10 years. And that doesn't sound like a lot when you look at it at the start. But when we also look at our failures, about 20% of our revisions are re-revised within 10 years. And I think that's a very high number, and that's an unacceptably high number. So as our numbers of primaries go up, our numbers of revisions go up, these re-revisions are becoming a very significant burden on our healthcare system. So one of my main issues, therefore, and I think our main agenda is to reduce the re-revisions in hip and knee surgery, but today specifically hip surgery. So as you know, in Australia, we like to be very proud of our National Joint Registry, but it's also a very important tool for research, as well as looking at outcomes for surgeons and for implants. So at the start of our journey, looking at conservative revision surgery in 2014, we began by looking at where we were at in our department, which is a tertiary referral centre, a revision centre, and looking at the reasons why our primary joints fail and the reasons why we move on to further revisions. When you look at our primary joints on the left for our centre versus all Australia on the right, then our reasons for failure are pretty similar to those through the rest of the country, with slightly higher rate of revision for loosening. But apart from that, we were doing a similar job to everyone else. So that's pretty good. But it's not all good news. We also started looking in 2014 at our rates of re-revision and why our cases got re-revised. And at that point, we discovered that despite being a tertiary referral centre, we actually were doing a lot poorer than the average for other Australian hospitals. And we actually had a re-revision rate of almost 30% at 5 years. I was actually quite surprised that those values were that high, but that was our figures for our department at that time. We decided at that point that to try and tackle this problem, we had to look at a better diagnostic and management pathway for a revision of the patients who've had a primary joint that's clearly already failing, to try and improve their outcomes, not just immediately, but moving forward from that surgery. We thought there was a few ways we could tackle this. And the first important thing, which I think is very important with conservative surgery, is we had to have a better and more accurate diagnostic pathway. And I think prior to that, we really didn't have a good pathway. Patients were just revised if they were loose or they were sore. One of the main focuses of this pathway is to make surgery less invasive. And clearly that makes surgery less dangerous for your patients and also costs less for your hospital. And we started looking at bone preserving techniques at that time. And that really was to move in on trying to preserve and reduce bone damage doing femoral revision. And it clearly saves bone for the future. But the main reason we're doing that was not actually just to save bone for the future. Work from our own department and other centres was showing that a more conservative approach with better diagnosis also leads to lower re-revision rates. And this really has been the thrust of our philosophy for the last 8 years. So when it comes to femoral revision, one of our focuses has been looking at metaphyseal loading stems and looking at the fact that these really are more physiological with less stress shielding than distal fitting stems. And one of the important points of this is that approximately 90% of patients don't need a distal fitting stem. Because if you look at patients that are Periprosthetic 2A or less, they don't need a distal fitting stem. They can do perfectly well with a metaphyseal loading stem. And this works very well both for your aseptic loosening cases and also cases like second stage for infection, which are quite common in our centre. And it obviously, as well as preserving bone and being less invasive, saves you the distal fitting option for future surgeries, which are likely to occur. So basically, we broke down all of our revisions. When you take all of the different classifications and all the different pathways you can go on, after going through all this work, our femoral revisions were basically based into two groups, everyone on the left and everyone on the right. So if you're a Periprosthetic 2A or better, you don't really need a distal fitting stem in most cases. And if your cement mantle is no longer intact or you're cementless, you really can go for no need for an osteotomy is easy. You can just have a metaphyseal loading stem, or you can do an osteotomy, but only if required. If your cement mantle is intact, we strongly recommend the idea of doing cement and cement revision, and we'll get to that later. And then a small proportion of your patients, which is only really about 10%, that have non-supportive bone, then go on to have a long distal fitting stem, or in the severely complex cases, tumour prosthesis or endoprosthesis. So to have a look at how this works in practice, this is one of our cases, a 73-year-old man with a loose stem with subsidence. It's an early failure. He's really failed only 3 or 4 months after surgery in another centre. And you revised a proximal loading stem. You can immediately weight bear and you get a good result for your patient. And this is what we're presented with a very short subsided stem preoperatively, really quite a disaster in a patient only a few months post-op. It is revised to a proximal loading, metaphyseal loading stem, can weight bear immediately. We've restored the leg length and offset and a good result for the patient. Another common scenario in our practice obviously is infection with an infection MDT centre, and we commonly have patients coming in for 1 and 2 stage revisions. And again, a patient who's had a prostalac in the past and a 2-stage procedure on the left can revise to a metaphyseal loading stem on the right with a good result, immediate weight bearing and good preservation of bone stock. As we said before, cement and cement I think is very important and shouldn't be underrated. Removing cement causes a lot of blood loss, causes a lot of surgical time, and can cause a lot of damage to femoral bone. And if your cement mantle is intact and you don't have infection, you really should consider cement, especially in the older patient. And you have to remember that The new cement mantle has about 94% the strength of the old mantle, and probably better than the bond of the old mantle with the bone. And you can use it in some of your periprosthetic fractures as well. And the last thing, which I always think is a strange one, but I think it's important to bring up, is that ETO can be conservative as well. And we use a lot of extended trochanteric osteotomy. And I actually think it's a less invasive approach than not doing an ETO and causing more femoral damage trying to remove implants from the top. We use it a lot in infection because you've got to get rid of all the cement and all the bone plugs to clear the infection. It allows good stable reconstruction of the femur and immediate weight bearing, and you can still use a proximal loading stem. We commonly use distal stems in this technique as well. So obviously we like scary pictures, so it's good to finish with an example of a picture where you can't really get away with not using an ETO in this case. And I think that it's actually more conservative to do the osteotomy than to destroy the femur and the bone stock trying to hack away from the top to remove a very difficult implant. And this is a young patient who's playing tennis when his extra stem failed. And I think he had an undersized primary, but he had an ETO, which is less destructive than the alternative, immediate weight bearing, and a good result. So for the last 8 years, our philosophy has been very strongly guided towards more conservative revision of the femur. We think it's more physiological and it certainly saves bone for the future, and we cannot overemphasize the use of using metaphyseal loading stems to try and achieve this. But most importantly, as well as saving bone, it's been clearly shown to reduce the re-revision rates for our patients in the future. And we should remember that an ETO can actually be considered a conservative approach in the right position, and cement is not something that should be discounted. Since taking on board these changes 8 years ago, we have found that our re-revision rates, which were the green light at the top, which were much higher than Australian average, shown in the yellow and the red, we've now had a significant drop in our re-revision rates. We're now better than national average as opposed to worse than national average, and our drop is statistically significant and a great outcome for our patients. Thank you very much.
Thank you so much, Chris, for a fantastic talk. While we're waiting for any burning questions to come up, can I initiate something? So, okay. As you mentioned that anything better and about type 2 is great to have a conservative femur revision.
Yes.
But then you would have a situation where a femur is in the process of losing bone stock, and the pathology is still going on. So would you actually go in for an earlier revision in a scenario where you would actually observe that particular stem for a longer period of time because you want to do a conservative procedure, rather than just wait out to actually when you would need to do a revision and the patient becomes symptomatic?
Yes.
So is there a fine balance you're playing with there?
There is a fine balance, but it also depends on what implants you're dealing with, because certain implants will deteriorate quicker than others. A very common implant in Australia is the Spectron hip, and we know that in that particular case, once you start to get osteolysis in the femur, if you do not proceed with surgery sooner, you'll end up with massive bone loss, and then you end up with a complex revision scenario. So in certain implants, we would probably move sooner rather than later. Whereas in other scenarios with different implants, you will see cases where you know that the progression of the femoral bone damage is actually going to be slower. So in those cases, you might not revise the femur at all. And obviously we're talking about femoral revision here, whereas in our practice, 67% of our revisions, we don't revise the femur at all. We just revise the acetabulum and preserve the femur. So in many cases, you're stepping in and revising the acetabulum before the actual femur needs anything done at all. So you can therefore save the femur. But in certain scenarios, you know that you know the implant types that are common in your own practice in your own country. In certain implants, you know that the lysis round about the femur is going to progress over a short number of years if you don't manage it. And in those cases, we would definitely act sooner rather than later to preserve bone stock for the future.
Great, thanks. Raj, you have a question.
Yeah,
Yes.
Chris, very nice talk and very good overview about revisions. My question is, you mentioned that the majority of 60% of your revisions are only in the acetabular side. So what is your take on the change of the femoral head from the femoral side, the head part? So if you are using, you're going to retain the sleeve, if you're retaining the taper, so what implant you will choose for changing the head? And if
Yes.
at all, if you're changing a ceramic head, what is your option?
Okay, that's actually a very tricky question. The the perceived wisdom on that at the moment is that if you have a ceramic head, you have to use a ceramic head with a sleeve. And I think most surgeons would swap a ceramic head for a ceramic head. There's a paper came out of our joint registry just last year which showed that whether you use a sleeve or not has no impact on the re-revision rate. So that actually, so not using a sleeve when you revise the head, we think doesn't matter. So it increases the cost of the device, but doesn't reduce the re-revision rate.
Yeah, in Journal of Arthroplasty, in 2021, they have published an article saying, if at all, if you are using a ceramic head, it is always better to use a sleeve. Even though the ceramic is very good nowadays, but that's what they have published. But if at all, if you are not using a ceramic head and if you are using a metal head, are you happy to use a 36 metal head on a damaged stepper? I
think the general agreement in Australia at the moment is that if the trunnion is mildly damaged but is still, functional, that you can get a good interlock, most surgeons would use a 32 or 36 head and save the stem. There was a vogue about 5-10 years ago where quite a lot of surgeons would revise the femoral implant for trunnion damage. But if the trunnion is, mild trunnion corrosion is there all the time. You see it in cases every day. But if there's very mild trunnion corrosion, most of us would put on a metal head and save the femoral implant. Some surgeons would use a sleeve in ceramic, but if there'd been a metal head before, I think a lot of us would still use a metal head and try and save the stem.
So what is the registry data on 36 metal head, cobalt chrome metal head, 36?
The registry for primaries suggests that 32 or 36 is about the same, doesn't matter. I think a lot of surgeons look at, I cannot quote exactly on that in the registry off the top of my head, but most surgeons, I think, in revision would probably head towards a 36 if they can. There's a growing trend. The evidence for it is scratchy, but there's a growing trend among surgeons that if they can't get a 36 head, they would consider using a bipolar head, a dual mobility head. But certainly 36 is probably go-to size.
Thank you.
Yeah, thanks, Raj. Can we quickly go on to Pradeep's question and then Dr. Rajiv, and then we move on? Very quick questions, please.
Chris, this is a question about the chorial revision stem. In most revision situations, when we remove the chorial, the surface of the bone that's left behind is not all that great and is definitely not conducive for any hydroxyapatite bonding. So when you're putting a chorial revision stem, are you sort of expecting any bonding, or is it only just going to be a fit that you're looking at?
That's a very good point. Certainly the way you prepare the chorial revision stem is very different. So it's broaches, sorry, it's late at night. Its broaches are actually a lot sharper than the primary ones. So it tends to freshen up the bone surface quite well when you actually prepare the bone. And it actually seems to integrate very well. I was a little bit skeptical when I first started using it. When I first started using it, I was using more distal fitting stems. But it actually fits well and integrates very well. But as I say, when you've got reasonable bone stock and you use the revision broaches, they do actually cut away a little bit of the surface. So you do get a better, rougher surface than you start with. Although I admit it's not as good a surface as in a primary when you've got great cancellous bone that you're going straight into. But they do seem to integrate well. I was initially not sure myself, but having used them for a few years now, they grow in very nicely.
Thanks, Chris. Thanks, Pradeep. Dr. Rajiv, before we move on to Bodo.
Chris, one short question. The conservative revision in a acetabular situation is the most difficult aspect. What is your preference in terms of the implant? If you have a medial defect, but you have the surrounding bone available, do you necessarily go to the cage, or are you okay with the trabecular metal cup?
I think the acetabular story is more complicated, but it is a bit like the femoral story in that you have about 4 or 5 different subclassifications of acetabulum, and they're basically good or bad. So unless they're very, very bad, we usually use a hemispherical cup. So you use a revision, like a Zimmer revision cup or a DePuy revision cup with a couple of screws. If you start to get significant bone loss or ischiolysis, and you're really getting into those severe cases, more inclined these days to use custom acetabulae, because the re-revision rates are actually much better than cup cage. And I use cages very infrequently now. Mainly not because you get good hold at the time, because the cages fit well and you get good hold at the time, but the re-revision rates for the cages are higher. So I'd either use a good hemispherical cup and just use some bone graft and screws, or I go to a custom acetabulum.
Great, thanks. So if we can unshare, Chris, we can move on to save them when you can and save them as a rule and a principle. So Bodo for histobone and fraction bone grafting. Thanks, Chris.
Thank you.
Can you share your screen, Mr. Prabhat?
Have you got, is it coming on?
Not as yet. We can see you. Yes, it's coming on. Yeah, we can see it now.
Brilliant. Excellent. I'm not particularly good at modern technology, as you know.
You can just go into slideshow and it will show up as a complete screen.
Let me just get that line down. Slideshow. There we are. I'm the old-fashioned one here, I guess, and you can see I still wear a white coat. Why is it not doing?
You can go on to the third icon on the bottom right of your screen as well.
Let me just see. It says
we can see it on your still lower down on the right, bottom right. A little further. Yeah, there you go.
That's it. We're in. I'm the old-fashioned one here. I'm the last one actually of the old generation. I use cement. I use trochanteric osteotomy. I don't split the femur. I think it's a euphemism to call splitting the femur an extension of the greater trochanter. The greater trochanter is an apophysis and not part of the femur. And of course, cutting the femur to me is just something I may have done it once or twice, but not particularly successfully. And I don't like the idea of breaking cortical bone apart. When you take the trochanter off, you typically get the way into the joint. That's how I've been taught. And of course, here at Writing, we've had one advantage. We've seen things over the last almost 60 years now. So in a way, I've seen primary surgery go to 50 years, and I've seen revision surgery go to over 40 years. And of course, it's always done with the same philosophy and the same rationale in the background. Your cement components for fixation. And of course, when you have had what we have at a Writing, when you've done a lot of work, you will come back to do revision work on your primaries. Michael Blesky always used to say 10% of your own work, and that's when you're good, will come back to you. This is Michael Blesky. Abe knows that gate. This is us in younger years. Paul Siney on the other side on the other side of that photo of the group is actually my research assistant, senior assistant here, who has helped me with that presentation. This is the same door that John Charney went through in the 60s and 70s. And it's still a privilege to walk through that door every morning. It's actually cracky. Some big surgeons have made their mark here at Wrightington and can use the same way in. Revision surgery. Johnny starts to work at Wrightington in 1962. For the first decade, for the first 6 years, there is no revision for technical failure of components. After 6 years, the first stem breaks. 1968, the first stem revision happens. And of course, by the time you do 500 a year, per year running, you will end up with quite a significant number, and revision work starts creeping in. I've done one of John Charney's, or redone one of John Charney's revisions from 1974. She was a 19-year-old, operated elsewhere in the country. And of course, when that failed within a few months, she came to Wrightington to have this one redone. That is the one revision that I've seen of John Charney is going to 34 years. Overall, the revision rate is around about 20% in our hands, not because it's our work, but of course, we also attract work from outside. Typically, it's the loose socket. It is often enough. It's not far off. Loose stems are an equally high number. Infection is not such a big risk. Dislocation, neither. And of course, the point of the whole story is when you do revision surgery, you need to prepare for the future. This is a cup arthroplasty in a young patient, revised to a Charney hip proper initially, and then re-revised with bone graft to make good on the socket. You can see the stem remains the same. The rationale for bone grafting is quite obvious. You create immediate stability. You create a substrate that the cement can bite into. You don't have to worry about fixation afterwards. By the way, the mechanical fixation on the day that you do it with bone grafting is superbly good. I had to have some taken out again because I wasn't quite happy with the socket position. And even though it's not biologically fixed, mechanical fixation remains good. And the last few stem revisions for a broken stem that I carried out with bone graft were actually fantastically hard work to take out, probably harder than non-symmetric components. Of course, it creates a biological response to the host. It makes bone stock back again. And what you can do with that technique, you do not have to go bigger for size of components. Why does bone graft work? Mother Nature wants to heal, and fractures heal because Mother Nature wants to. And the less we interfere, the better the healing is. And as soon as you understand that principle and you can respect the biology of fracture healing, you use the same for the approach, trochanteric osteotomy, as you do for the bone grafting to make good on the defect. You can see this is actually a proximal femur, remove the cement, but only the cement. It's a distally fixed components. The fracture side is left completely alone. It reconstitutes the bone very nicely. Now, if you had to take that stem out for any particular reason, you have a proximal femur to work with again. I would pack that up with bone, of course, and then cement, but you can go for a short component at that point. And I wanted to point that out in this particular case. I know this is an acetabulum, but I wanted to demonstrate the physiology of bone loss. The original X-ray, the preoperative X-ray, wouldn't have given you quite the impression how big that defect is. You can see how far-reaching that bony defect is. I was in theater at the time, and I didn't feel comfortable taking the socket out because that would have disassociated the pelvis. This is, of course, we call it the triradiate cartilage. This is the area when you have 3 points of the pelvis fixed together. Taking out that component would make that a flail socket. What I decided to do instead at the time, I packed that socket up. She was painful before the operation, despite well-fixed components. The funny thing about that one was actually the learning curve about it was not to rise components unnecessarily. But what I also did actually show the next morning from surgery and still in bed, she says that pain has gone. So this was an impending fracture because of bone loss, and just stabilizing it with bone packed into the defect made her pain free. You can see the osteotomy. This was originally ITO to LFA. So she had an ITO initially, then an ITO to LFA, and then that revision. Watch what happens. This is what Mother Nature does with these things. And one of the advantages working at Wrightington is to do the follow-up clinics, because then you can understand what Mother Nature does with them. You can see that the pelvis has remodeled to very much the same structure that we started out with. I had left the socket in place. This is 2008, I'd done that. You can see 8 years later, the socket is starting to fail. The stem is still good. We're looking at almost 40 years at that point. And at that stage, you can go in with a normal revision of the acetabulum. By the way, the osteotomy is done 5 times now. So as much as we talk about trochanteric osteotomy and worry, that is not a major issue. It does happen, and of course it's a worry, but actually there is no gentler approach into the hip joint than using trochanteric osteotomy. Charney has demonstrated that 60 years ago. I still hold to it. And you can see what happens 3-4 years later. Bone graft incorporating, the pelvis is rebuilt. She's got a new socket in, the stem is the old stem. And she's still only a young woman at this stage. So the experience with bone grafted revision surgery, it gives you immediate mechanical stability. It's immunologically well tolerated, and you have a mechanical scaffold that creates some biomechanical incentive to make a new skeleton out of it. Of course, bone grafting is not just, oh, throw some bone in, it'll happen. You need to have a bit of an idea of how you approach bone grafting, both for how you pack it in, how tight you have to pack it. And of course, it comes with experience that you get better at things. And when it comes to bone grafting, one of the reasons why we looked at bone graft substitutes, of course, there is an expense. You need to procure it. You need to test the patients and test the bone. You need to store it. You need to have a team in the background that runs that bone bank for you. And there's always the slight worry about disease transmission. But when you look at the literature and our own experience here at Wrightington, it's not an issue really. You can be actually quite generous in the selection of patients you take the bone from. Demineralized bone was another option. Mineralized bone substitutes have not worked in my experience. Demineralized bone, I've only left that slide in just to show you what it looks like when you pack a femur and prepare a femur so you can cement back into it. And you can see this is actually squishy stuff in inverted commas. This is my own blood, by the way. This is an experiment we used to do in the biomechanics laboratory. This is what it then looks like when you have the cemented component inside and nothing has shifted, and that thing is absolutely rock solid. You can see with DBX, I've got my own experiences. It's just superbly expensive, and it does work well, but it doesn't work any better than bone graft itself. And you can see the socket is revised and the stem is revised, and it makes new bone over a while. You can see cavitation of the femur. By the way, notice the socket remains the old socket, and it shows almost or no measurable wear really. But look at the defect in the cortex, how it rebuilds. This is the acetabular grafting, just to show you actually you can apply bone grafting on both sides. There isn't a significant difference in how you apply bone grafting. You need to have a bit of an idea how you prep the bone, how you place the screw, and of course you need to practice and do it regularly. How do I prepare bone graft? When you look at the femoral head, a lot of people use lots of tools. I think if you best use your hands. We run workshops here to demonstrate to surgeons you can do it. Anyone can pick it up in the morning. You can go home afterwards. It's actually, you've done it yourself. You can pack that. And you can see that in plastic bone practice, similar to what we've seen beforehand. This is what it looks like when somebody comes in, preps the bone in the morning, learns how to do it, does it himself, when it looks actually pretty darn good. And you can see it's a stable construct to cement into. So how do I prepare bone? You need to take the gums and the cortex off and the synovial tissues. When you get to it, you lose about a third of the bone in mass and volume. But then you have cancellous bone only, nibble that. What we need for expertise, I think actually what we have in our fingers. That's one of the reasons why I'm critical about robotic surgery. It takes your skill out of your hands. The more you have in your own hands, this is like baking and cooking or making a Stradivari violin. What you have in your hands is the expertise that you have. And feeling the quality of bone gives you an idea how big chunks you want. You can see this is prep bone, but not washed. You need to wash bone. What that allows you to do is get the fat, the marrow, the blood, and all the cellular material out of it. It reduces disease transmission, and you're really only after the hydroxycalcium apatite and tricalcium phosphate. So you're really only after the mineral phase. Take that stuff out. In the healing process, as we all know, the amount of necrotic tissue or cell tissue that comes in as debris will turn the milieu in which it's healing acid. But bone, of course, is an alkaline medium, so it wants to heal in an alkaline prep. Once you've prepared it, you can see it's a completely different material. We have five instruments to pack the component, and you can see that's how bone looks when it's processed, ready to pack in. The osteotomy, you can see prepped already to close at the end of the procedure, packing it through the tube to make good. And you can see how you can reduce the hole in the proximal femur to a normal looking cavity. This is actually just a view further down to see that even cavitation is filled in as you pack it down. You need to have a rod inside. What you can't do is just fill up with bone and then pack the rod down to find the way. You will find the via falsa. So you need to have a rod to show you alignment in the canal. And then you need to have a spacer that gives you already the space, because otherwise you're going to explode that femur. But then you pack from the top down and it fills it up very nicely to a bone bed that is almost as good as in primary surgery. This is what it looks like beforehand. This looks like with cement on it. And it doesn't, you can see that's the same size that we use for primary surgery. And after cementation, it's just a normal femur again. Look at that femur. You can see a proximal defect, thin cortices, a long stem already in place. Of course, why? Because there's a bone block or something down there that shouldn't be there in the first place. Now, this is not a reason not to go for a shorter stem. In fact, this is a reason to go for a shorter stem, because you allow the body to reform a femur. This is immediately after surgery, and see what happens 10 years later. We've got a hip now, you got an x-ray of this one at 20 years, it rebuilds the cortex because the loading in the proximal femur is retained. Look at the acetabulum, it doesn't even look any different. The non-cemented component on the other side shows significant stress shielding. Looks a very unappetizing right hip to me. When you look at this hip, you can probably just notice on the right hip, there's a stem fracture in there. This is a revised hip I did in 2005. Why does he break his femur? Why does he do it twice? He plays golf 4 times a week, and he's a heavy lad. So by the way, he comes back at 12 years from the revision operation, and you can see the left hip is the primary. The right hip is already 1 revision. This is the revision the second time round, and this is 3 years later. and the components remain the same, and it actually doesn't look much different to the primary operation that he's got on the left hip. What I want to demonstrate is trochanteric osteotomy is the approach of choice to get into the femur, to retrieve components and bits of components, but also to retrieve cement. This is, of course, one of the very small patients, and this is Charlie's operation at its best, the versatility of the operation at any stage, at any size. And you can see this is a 4-foot patient with a 38 socket. These are customized components that stem length is probably about 5 to 6 centimeters long. Now, what you need to do is retrieve the cement. And this is the CDH stem of the C-stem series. And this is the long, I call it the long revision stem for her. But you can see how it rebuilds the proximal femur very nicely. And we're looking at about now 22 years from the primary operation. Akash Raogi and Naveen Lokikeri had been fellows here a couple of years ago. They looked at everyone's work, and they've looked at an average of 10 years follow-up. And you can see we're looking at 168 revisions. These published that. There was actually no issue really with the stem. 2 stems had been revised in the course of time, but not necessarily because of a problem with the stem. And of course, do we talk about bypassing or going longer? No, we don't. You want to reduce it and you want to get back to a shorter length stem, and you can do that very nicely with bone graft. So for me, bone graft does indeed work. It reconstitutes loss of bone, and you can get to the normal size components that you want, and it avoids the proximal stress shielding. You retain bone, so you have a chance to go back at some later stage. That's my talk so far, and I'm hoping for some interesting and critical questions.
Thanks, Bodo. It's a fantastic elucidation of what has worked for the longest period of time, the longest follow-up. It's not been followed, it's not been taken up, but it does have the longevity of follow-up for everyone to see. So Dr. Rajiv sir has a question. A very quick one before we go forward, and we'll collect the questions. I'm sure there are. Even I have a couple for you, so maybe we can do them at the end.
Thank you, Mr. Bodo. I think it was a wonderful presentation, especially of the cementation and the revision situation, the cemented stem. To see this beautiful cementing, would you like to share with us your technique of cementing, which seems to be very, very good?
There isn't actually, you know, I grew up, I started surgery in the 90s. That's just a transition point where they stopped finger packing and started using the gun. Then we talked about the vacuum mixing, the high vacuum mixing and stuff. It's probably not that. It's probably just to get to know your cement. Once you have a feel for your cement, you can actually titrate that well. What you need to do, that's what my teacher, Michael Vesky, always taught us, control the cavity. So there mustn't be any blood or anything in there. And you fill it up from the top, from the bottom up, compress it down and hold steady. We're so much in a rush when we go into the operation, when we close up. But the most important time of the whole operation is when we hold still. When the cement is in, the component is, and we hold still. We tend to forget that. I have to remind myself regularly that this is the most critical time of the procedure. And compression, pressurization, compression, and it's really just the feel for your own cement. Just keep to one cement. Keep to one theater, check your environment, make sure that you control that. And once you've got that, you'll get the feel for your own cement. That is probably the best advice I can give you.
All right. And what do you take precaution to prevent the embolization? Because that remains one of the most important factor, which is not in the surgeon's head.
No, go late. The advice is go late. Don't go early. The embolization happens for 2 reasons. One, you have left material inside the cavity. And that's, of course, easier on the femur to do than on the acetabulum. The acetabulum is a wide open bowl. What I use regularly is hydrogen peroxide and a swab compressed into the acetabulum. In the femur, I'd also use a hydrogen peroxide swab, but actually filled up from the bottom up. This is not possible when you do revision work like I've shown you here. The cavity is too small, but I leave the phantom in. I'll leave the phantom in until the last minute before you just swap it over to put the gun down, because then it can't fill up with material. Just, yeah. And then you go rather later rather than early.
All right. Yeah, thank you so much.
I think we'll move on now. We have 3 questions for you, Bodo, but I think we'll take them in the Q&A session. Finish with the talks first. So while we'll request you to be around, and I have noted down all the three. So can I request Pradeep to go on with his talk on stability in total hepatoplasty? So what do we need to do which we don't do in our hips and knees?
Thank you, Abhay. So, when we're talking about the soft tissue stability, I think that we should always mention that the cup position is very important, both in terms of inclination, version, as well as a combined anti-version. But my brief here should mainly talk about the soft tissue balancing and how that affects it. I mean, we all know that we need to recreate the length as well as the offset. And in this case, obviously, you can see that the offset is less. And so there's likelihood of dislocation. And so therefore, what should have ideally been used probably would have been a higher offset stem. Now, what I want to submit is that what you want to try and recreate is not really the patient's femoral offset. What you really want to recreate is a combined offset. Or should I put it more this way? It's the effective offset, or the distance from the lateral wall to the trochanter. Because if you increase that effective offset, you're going to cause a lot more lateral soft tissue pressure, trochanteric bursitis, and various other issues. So you want to try and retain that particular offset. Now, if you try and put the cup back into the correct position, for example, this kind of protrusio, what's going to happen is that, and you're going to use your corail, which is probably what this kind of normal femoral stem would have used with the normal femoral offset. It will cause significant lateral pressure here. And so what you should not do is you should not use a standard offset, but you use something that's going to recreate this effective offset, something with a much smaller offset. So in this particular patient, we have used actually the DDH stem cemented. Of course, we could have also used a another stem, which is much smaller offset, which would be your SROM. Now, another clinical scenario, you're doing a surgery and then you centralize or you push this cup in a little bit more. If you're going to use your standard femoral offset, which you measure preoperatively or peroperatively, you're going to have a situation where the whole soft tissues are all lax and you're going to have a dislocation. Now, the tendency for most surgeons is to go ahead and put a longer neck. And if you put a longer neck, this is just not the thing to do when you're centralizing. For example, this is not my X-ray, but just to show you, the surgeon has actually put in longer necks to get the stability, which he got, but it's going to be at an expense of length. And the reason why this is so is that if you want soft tissue balance without increase in length, you need to use a higher offset stem. By virtue of the fact that the neck is at 45 degrees, every time you go from a -3 to 0 to a 3, you are going to increase the length in addition to the offset. So you must be careful about what you want to correct. Which is why it's very important to also do a per-operative templating. It doesn't matter what it is. The two things that you need to look at when you're looking at soft tissue tension, one is the effective offset. That is the length from the lateral wall to the trochanter. And then you also need to adjust the length to whatever correction that you want. But you need to do this per-operative templating. The other thing is you need to be aware of what kind of stems you have. Now you have the standard offset and the high offset stems is available. And the important thing to note is that in most situations, except for example, in corail, the angle is 135 degrees for both. What the difference is the horizontal offset. So you can achieve the same length with a different offset. But you also, for example, in the corail now, for example, you have the standard offset and the high offset, which is 7 millimeters more, but you have one with a decreased length. So both are high offset. The coxa vara stem is one where the angle is about 125 degrees. So the angle is slightly different, not 135, but 125. So with this family, for example, in corail, you can actually have a wide variety of soft tissue adjustments that you can make both in length and in offset. You can choose per-operatively what you want. Now, polar is slightly different. For example, here you can see their high offset stem, so-called high offset stem, is actually not a high offset stem. It's actually a coxa vara stem because the angle is 126. Now, if you're going to sort of compare stems, for example, the corail standard stem is 38.5. This is a size 9. And their high offset is 7 millimeters more. And the polar standard is somewhere in between. Now, you need to know these if you're going to, depending on what stem you're going to use. You can see the polar high offset stem is actually a coxa vara stem, not as much as the corail one, but it is not just a plain high offset stem. So you need to be aware of these. Polar also has a valgus stem, which is not available, I think, in India. And of course, you got the SROM, which has got a 30 mm offset. Now, why in the world would one use a 30 mm offset when your normal offsets are nowhere near that? And that's when you want to adjust for length. So if you decrease your offset, you'll get a lot more soft tissue adjustment where you can actually get the length back. So you can use a much smaller offset in such situations. But sometimes even if you use your smaller offset, you still will not be able to get the head back into the cup. And the reason why that's so is because of the hamstring tightness of the infratrochanteric shortening. So in that kind of situations, you have to compensate for that by doing your subtrochanteric shortening. I call it actually the LT sign or the lesser trochanter sign. If you see that very close to the teardrop, be prepared to do a subtrochanteric osteotomy. It's so similar. This is again a quite controversial one, but this is a 4'10" a lady with protrusio, and you can see that if you're going to be thinking of putting your cup back in the normal position, here you can see that the LT sign is again positive, very close to the LT. Very short lady. So if you're going to go and try and put a normal stem, you're going to get way out. So we put a SROM, which has got a 30 mm offset, but that too still would not go in because the soft tissues were too tight. And you can see the native offset itself is very, very small. So in this kind of a situation, what we actually did to get the head back in was a subtrochanteric osteotomy. And it's not just one side, but we had to do it bilaterally, as you can see. The reason for the plate is because of the metaphyseal-diaphyseal mismatch that we had to do. Of course, the whole scenario can be different if you're going to do a trochanteric osteotomy like what was shown different previously, but I'm not going to go into that particular area. Now, the same situation can happen in the revision scenario also. You can see that the LT sign is very close up there. If you want to get that head down, there's going to be, we must acknowledge the fact that there is going to be tightening there. In fact, we did first try putting an SROM with a very small offset, and we did try putting it back inside. It kept dislocating, and so we actually had to go do a subtrochanteric osteotomy there and get that vertical offset back and get that head back. That was the only way we could get the head back into a stable position. So sometimes we have to use a small offset, but in addition, you may have to respect the soft tissue tension down below the hamstrings. Now, in situations when you have a huge metaphyseal, loss around the trochanter, small losses may not be that much of an issue, but when you have large losses like this, you want to use a high offset stem, which is what most revision stems are. But in addition to that, what you really need to do is you need to get a good distal fit so that you can then build it up. Sometimes using monopolar stems can be a problem because if you're not careful, you will you may not get a good fit distally because you want to try and get that stability proximally. So don't depend on the dual mobility or various other things, but depend on a good fit and a good balance. So in this situation, what you really need to do is get a good distal stability and then build up the proximal bit using various different lengths to get your soft tissue stability. So in summary, basically what I want to say is that don't always try and recreate the patient's own femoral offset. What you really need to respect is the effective offset. The second thing is be aware of all the different stems that are available and the different offsets that are there. And that will help you get a better soft tissue balance. And don't underestimate the effect of the infratrochanteric shortening. Look at that lesser trochanter and see where that position, that will give you a sign as to what you may need to do. And the other thing is when you have a huge loss proximally, don't forget, get a good distal fit first and then build up proximally. My next speaker will actually speak about how you can use monopolar stems also in this kind of a situation, but that's a rare situation and he'll elaborate more about this. I think Raj is going to talk about it. I'll stop there. Thank you.
Thank you, Pradeep. Thank you for a lovely talk. And we have a quick question from Dr. Rajkumar.
Pradeep, as usual, very good talk and very informative. Just a quick question on one particular case which you showed, the protrusio with bilateral protrusio with DOR type C canal. So in this situation, a lateralized cup after bone grafting and a cemented stem with a DOR type C would have solved the issue and avoided the subtrochanteric osteotomy. What is your take?
So we did actually have the DDH stem and we did try that. I guess we could have done a trochanteric osteotomy and done it like what was shown by the previous speaker. But without the trochanteric osteotomy, we were not able to get that in, which is why we then had to go to the SROM, which had got a 30 mm stem. But even with that, we could not get it in. So we went through the sequence of exactly like the first X-ray that I showed you, tried the smallest DDH stem, cemented stem, and then could not get it in. Now you can say, yes, we can sink the cemented stem in. and therefore get your soft tissue balance done better. But if you sink the stem in, that will cause an impingement, because as it is, you got a small offset. And if you sink your stem in further, your vertical offset is going to come down and you're going to get an impingement, unless you do a trochanteric osteotomy and pull it down.
Dr. Bodo, his comment on this?
Can I just finish the questions, Raj? Otherwise, we'll get too late. If you
Oh,
don't
okay,
mind.
please.
Yeah. So just before we finish the didactic talks, there are a couple of questions which are for Bodo while we are discussing the cemented stems. So one of them is from Dr. Rakesh. He says, it's Mr. Purbach. How do you adjust the leg length and offset in your cemented stems? So what do you do?
That's the advantage of cementing. You can place them where you want to. And of course, I mean, the system was worked out on cadavers. They studied cadavers all over the world. And they got the range because of, I think, 3,500 femoral cadavers measured, actually the femur measured. So the system offers enough versatility. We mustn't forget, Charney had two components. Charney started, in fact, actually with only one size component, and it used to work. And this is the beauty of Charney's system, especially when you use trochanteric osteotomy. And you're absolutely right, Pradeep. That's exactly the point. When you take the trochanter off, the soft tissues will follow. It's almost like on a clock dial when you bring them down. For then actually to sink the component in or not to bring it out, we're talking about minute changes, but these are almost the field situation in theater when you say that's hard enough or not hard enough. The broaches for the C-stem were actually very, very useful to titrate soft tissue tension and offset, and you can work it out from that. The range is good enough to do it comfortably. But as I say, Charney had two components and it worked for every size patient, and they did short patients as much as tall patients. The cemented component allows you the versatility of that.
And just to add to this, what would be your rehab protocol, Bodo, after impaction grafting and the cemented femur prosthesis?
I keep them partial weight bearing for 12 weeks. And my patients stay on crutches anyway for 12 weeks for the trochanter. That is probably not quite so necessary. It's 6 to 8 weeks and you see the trochanter normally healing. But when you look at even Andy Murray, the big famous tennis player, motivated as he was, didn't start playing tennis before 4 months were up. I think we're chasing our tail, trying to tell patients they can get up the next day and go back to work. That's not how it works. Most of our patients will tell all of us, and it doesn't matter what component you use, which approach you use, it takes a year before they feel comfortable. So give them the time to recover. Don't make it, it's not a sport, it's not a competition to get them the fastest back on track. Andy Murray took 4 months before he started playing tennis. 12 weeks it is for me. Partial weight bearing means half body weight. Fractures need some loading. So you don't want them off, but you need to have some loading to go through it to make the bone graft work and incorporate. Does that answer the question, Abhi?
Great, absolutely. Probably we can discuss this further if there is time down after, because I have two more questions from you. One is from Ashok, who asks, basically, what is the end point of the wash in your graft preparation?
It's almost a visual. When you are happy with what the bone graft looks like, the yellow color that you've seen and the open porosity, 2, maximum 3 times is probably what you need. Sometimes when you have a very fatty one, but you need to do warm water. You need to have warm water. We take it out of the heating cabinet for the blankets. And the point is you can't wash dishes in cold water. Fat won't come out. You need warm water to wash fat. So it needs to be 25, 30 degree warm water to wash the bone twice, maximum 3 times.
Thank you so much. And another question to you is, what about the outcomes of cemented stem and small narrow canals? That's a question from Krishna.
That's the reason why I've incorporated my 4-foot patient. You can see you can do it, you can revise them, and you can even take out broken fragments, but only if the approach is good enough to do that for you. And that is with the trochanteric osteotomy. Just imagine in that 4-foot patient with a 5 centimeter component, you break that femur open because you want to get to cement. You can't really do it because then you can't fix it any further distal. You get unstuck on the approach into that joint unless you do trochanteric osteotomy. Does that make sense? Such a small component, if you break the femur open in the first 5 centimeters, and then the femur becomes even tighter, you can't ever get a component in that's so 4 millimeter wide and about 20 centimeters long to fix a proximal femur onto it. So the best approach, the gentlest approach into that femur is the osteotomy on the trochanter proper. and then you remove the component from the top downwards, prepare the bone, pack it up, and put a new component in. These CDH stems, the little one I had shown, actually, that in that bed of cross section isn't big any bigger than 4 millimeters in diameter. We're looking at tiny bits of steel.
Great. Thank you so much for all the questions and the answers. And may I now start the panel? And our first presenter there is Professor Shahid Noor. And Professor Shahid sir is going to talk to us on a case with SROM in type 2 and 3 defects. All yours, sir.
Thank you very much, Abe and Rajiv, for arranging such a wonderful webinar session and 3 excellent talks from our previous speaker. With this background of femoral revision in primary, complex primary and revision and conservative approach, I'm just going to show 2 quick cases.
You need to put here.
So the first case is a 74 years old female. She had a left intertrochanteric fracture for which a DHS with derotational screw was put in 3 months ago. And obviously you can see the failure. She had been unable to, she continued to have pain, difficulty in weight bearing. So how can we help her? What are the options of treatment and how would faculty manage this particular patient? And this is open to
may I request faculty. Chris to comment on this one very quickly. Please. What are the options of treatment for you, Chris? Is Mr. Wilson there?
Yep. Okay, okay. So this is 3 months post-plate screws. Well, I think that, could you go back to the AP X-ray, please? The previous one? Yeah. So I think it depends on your philosophy here, how you're going to fix this. You have to either fix it or replace it. I think if you're going to fix it, you're probably going to have to use something like a blade plate to try and get hold in the bone that's left. I have to say that in my hands, I would probably give up at this stage and do a replacement. I would take the screws out and I would put in an implant.
Do we have any other option than arthroplasty? So we've had a discussion with the patient that re-osteosynthesis or arthroplasty, and considering her age, we thought that we give her one option and she's on her feet. So this is exactly what we did. And we removed the implant. We did, considering her age and the abductor mechanism, we put a dual mobility cup. We understand that in revision cases, the rate of dislocation is high, and we use a SROM implant. And 3 months down the line, you can appreciate that the bone has very well taken and it's consolidated proximal femur. So she had a dual mobility cup on the top and a SROM implant. Obviously, we had given her supplement like calcium, vitamin D. And I've had a personal experience of using injection teriparatide in metaphyseal region, especially immediately post fixation, and it worked wonders both in proximal femur and in proximal tibia. And she's pretty pain-free. And that's it. Any comment, question, queries on this?
May I request Bodo to come in with your comments, please? What would you do differently? And your comments, please. Very quick ones.
A good solution. It's done the job very nicely. I would have grafted, especially since she's lost the bone. But look at the effect. Actually, Mother Nature heals fractures, and that's just the proof of it. With the pertussis situation, with the holes in the proximal femur, I would have put a bit of graft in to make it more stable. But just as good a solution. It's done the job nicely. Nothing much to add. My standard technique would be bone grafting, but Mother Nature heals. That's done beautifully well.
Darren, can I get you on this? A quick comment, please. Do we have Darren?
Yeah, yes. I agree. I think that I think a lot of us have lost the art of doing blade plates already. So a lot of our arthroplasty surgeons be called in to probably replace the hip. I think that given the age, was there a reason why a total hip was done instead of just a bipolar. Was the acetabulum compromised as well?
Yeah. The age was we just wanted to give her one operation and pain-free. And that's why we have put a cemented cup and a dual mobility to prevent dislocation. So I agree, there are more than one ways of dealing with same problem. And it depends on your experience, availability of implant, philosophy, and your personal experience.
So before we move on to the next case, your next case, there's a question in the chat box. Standalone metal back cups have poor midterm outcomes. Any comments on that before we go on to the next case, sir? Standalone metal back cups have poor midterm outcomes. Your comments, sir? Or any of the faculty would they wish to comment on that? Are we there, sir?
Yeah. So standalone metal back, in elderly patient, the literature says that there's no difference and there are 10-year survival even in primary hips in dual mobility. So most of the time I would use uncemented, but depending on the quality of the bone, I've had a vast experience of using cemented cup, and in midterm, I've not seen any drawback of using metal. So it's a metal cemented dual mobility.
Sure, so can we quickly go on to your next case, sir?
So the case 2 is a 60 years old female, had a left hemiarthroplasty for fractured neck of femur. 6 months down the line, she came with pain, and the lab work, including aspiration, was suggested of prosthetic joint infection with Staph aureus. So this is a case, she is symptomatic and a confirmed prosthetic joint infection with hemiarthroplasty on her left hip. So how would the faculty manage this patient? Chris?
Yeah, certainly. I mean, I think that this patient is relatively young, despite having a hemiarthroplasty in. So at the moment, we would manage this with a 2-stage revision. There is a growing trend in our practice to do 1-stage revision with Staph aureus because it's a very treatable organism. But certainly our go-to would be a 2-stage procedure.
I agree with you. I think management of PGI is a whole science, and you need to have a team. For example, managing a tumor, like a tumor board. So you need to have a musculoskeletal infection person, but ID person trained in musculoskeletal infection. An ordinary ID person is not going to work, and a microbiologist and help. So in this particular patient, we did a 2-stage, as you've mentioned, Chris, that we removed the implant, we put an antibiotic cement spacer with antibiotic, and after a course of 6 weeks, we went in and we did removal of implant. Here, the patient had a good quality bone, so we did an uncemented dual mobility and used a SROM type of implant. The calcar was missing, so it was a type 2 Petrosky, and we used your philosophy of bone conservation, and the patient was mobilized full weight bearing. So diaphyseal fixation is good, and metaphyseal we've used. So
may I just quickly request Dr. Raj and Dr. Rajiv sir to just one line, what would you have done anything differently?
Yeah, okay, the first point here is 2-stage revision. 2-stage procedure is a must in this situation, PGI, and I wouldn't have opted for a dual mobility for first instance, and then my go-to stem will be an uncemented short 190 distal loading stem. So these are the 2 options in the implant wise.
Dr. Rajiv sir?
I think Shahid, you have used a wonderful technique of two-stage revision, which is right, and all of us will do the same. As regards the implant, I would prefer to use in my hands maybe a Corel and not a dual mobility, as Raj said.
Very
because
quickly,
I
can
feel
I
that
just...
all these infected cases, the dislocation is not as big an issue because of the fibrosis. There is a lot of the tissues are tight. The dislocation is not a big problem in my hands.
Can I butt in on
the faculty? What do they say?
Yes, Bodo, you have something.
Sorry, can I
Yes,
butt in?
Bodo.
I disagree. I would have done it differently. Now, I don't think actually there is much rationale for 2 stages in a situation like hers. You've got actually an innate, you've got a tidy acetabulum to work with, and you've got a cavity. Now, how do we treat infection? Of course, it's debridement, and then you need to stabilize the soft tissues. But with a spacer, you don't get stability. What you then do actually is you use cement to give extra antibiotics into that joint. I sure would have tried this as a 1-stage operation with extra antibiotics into the cement. You get one operation and you get fixation at the same time. And I wouldn't hesitate one bit to use 7/8 of an inch diameter heads, 7/8 Charney hips. The thinking of doing something in 2 operations when you can do it in 1 operation actually doesn't appeal to me at all. Our experience here at Writing goes back to the 60s when, of course, the first bits of complications were infected joints. Charney didn't even put extra antibiotics into the cement because, of course, we didn't want to create allergies to these and actually also create immunity to the antibiotics. It was Buchholz in the endo clinic in Hamburg that introduced antibiotics into cement from the 70s onwards. And that technique has proven to be worth every bit of it. The only reason why I would do something in 2 stages is if the bone loss was so significant I couldn't put components in. But this case in my book actually asks for a 1-stage operation, especially because you can actually treat the acetabulum and the femur, and you achieve 3 goals: 1, debridement; 2, stability of components; 3, closing off the voids.
Yeah, great points. We can keep discussing this endlessly. A quick comment from Dr. Rajiv, sir. Very quick one, sir. And before we
Yes.
move on to the next case.
Yes, Mr. Bodo, I think that's a very, very right approach. Our only concern in a 1-stage revision for a infection is that the recurrence of the infection and the cost involved. So do you, just a quick response if you can, what antibiotics you use in your cement if you're doing a cemented revision for such a situation as a 1-stage revision?
I think the literature is quite clear. Aspirations don't really give you that much information beforehand. And of course, as soon as you apply antibiotics, you change the atmosphere in which the bacteria grow and you get a different culture next time. The idea of surgery actually is debridement. It's not the antibiotics that treat infection. Otherwise, you wouldn't have to do surgery. It is not antibiotics. It's absolutely just surgical debridement. Antibiotics are only an adjuvant. Normally we have gentamicin in it. I'll use some pre-mixed cement. Tecris in Italy produces that. They have vancomycin mixed in already. That's better than the hand-mixed stuff that we put together. The mechanical component changes, or the mechanical features of the cement change if you mix it in by hand. That pre-prepared cement does very well, adds the vancomycin to it. I will go chasing cultures, but I will not aspirate beforehand either. And in fact, yeah.
So sorry.
Shall we leave it for later, Abe?
Yeah, we can finish this one now and we'll move on. We can finish this now and we can move on.
The idea actually is that the goal is surgical debridement, fixation of components, closing of voids. The bacteria, actually, the more aggressive infection, the ones that pouring pus, are easier treated than the low-grade infections, by the way. If you have a sinus, this is typically a good sign because, of course, what do antibiotics do? They hit in mitosis. So the more turnover you have, the more pus you generate, the easier it is to kill the bacteria. It's the low-grade infections that I'm really worried about. And it almost makes no difference whether they're gram-positive or negative bugs. I mean, Peter Kay is our proponent for infected joints here at Writing. There have been plenty of publications over the last 2 decades indicating that 1 stage is the way to do it. The risk of a 2nd stage is actually no greater. In fact, it's lower than if you do 2-stage operations. When it then fails, you haven't lost anything, but you typically end up with 85% success rate in the first place. I've seen too many patients with 5 first stages, never gotten onto the 2nd stage because there was so much bony destruction at the time from that operation. I prefer a 1 stage if I can do it. The only reason why I wouldn't do it if I wanted to bone graft, because I'm not brave enough to revise a hip with an active infection with bone graft.
Thank you so much,
Sorry.
Bodos. It's opened the doors to so much discussion.
Sorry.
Thank you very much, Shahid sir. May I move on to our next speaker, a case on modular and non-modular stems, Raj.
Ali. Yeah, can you see my screen, Abhay?
Yeah, very visible. Please go on. Thank you.
Okay. Good evening to everyone, and I would like to thank Dr. Abhay and Dr. Rajiv for the opportunity here this evening and excellent talks and discussions. So to go on to the case-based discussion here, my topic is on modular versus non-modular femoral stem in revision THR. So this is the first case. I know even though it is a similar case like what Dr. Noor showed, he's a 63-year-old male with a failed implant here, and the head is already resolved. So I would like to ask anyone on the faculty panel their choice.
Can I request Mr. Smith to come on this? We've not gone to him. Everett, are you there?
I am.
Yeah.
Well, in my hands, I mean, I'm not a revisionist, but I've sort of obviously dealt with these many years ago. For me, I would be saying 63-year-old male, young man. The femoral head looks as though it has seen its better days. I would most certainly remove the hardware entirely, and I would turn to a total hip replacement. The choice of total hip replacement would be obviously based on the canal and based on the acetabular implant. And in my hands, I would probably do slight variation on Wrightington, and I'd probably do a cementless acetabular cup with a cemented stem.
Oh, cemented stem, is it? Okay.
Yes.
Okay. Any preference for this hybrid this thing?
I think I would do an uncemented stem, and I would, yep.
Okay. Okay. So I agree with Dr. Smith about the acetabular side, the uncemented. So here we can see that there are a lot of screws in it. Even though he's a 63-year-old male, he definitely has got a bone resorption because of the unloading he has underwent all this many years due to the failure. So once you open, definitely there will be a proximal femoral bone loss. The calcar is deficient here. So in this situation, what I did was a prophylactic wiring around the screw areas because of the screw sides are weakened one. And you can see the bone loss on the proximal femur. So definitely, and I know Dr. Bodo will argue for an cemented here, but in my hands, I will prefer a shorter uncemented fluted tapered titanium stem. Anybody would have done it a little different here, Dr. Bodo?
While Bodo is not there, Pradeep, your take on this one? What would you do?
I probably would have done something quite similar to what Raj did, but personally, I would be very scared about doing it at a one stage. I'm always worried about when there's metal, there's resorption, like to rule out infection, which is always a possibility with this kind of situation. But in terms of the final choice of implant, I probably would have done the same thing. I guess Chris would have used a normal Corel revision stem.
Yeah. Okay, right. So,
Mez, are you there? Can I request Mehul Acharya to just comment on this one? What would he do before we go on to the next case, Dr. Raj?
Yeah, sure. Thanks, Abhay. Yeah, so I would have used a very similar philosophy to Evet. I would have used a cementless acetabular component plus or minus screws, depending on whether they were necessary. And I would have used a cemented stem for the femoral side. I just think it gives you that versatility. I think if you've got a monoblock stem, you may compromise on that. If you've got a modular cementless stem, there are ways of trying to overcome that. But I again agree. I would have probably done it as a staged procedure, and I think having antibiotics in that second operation is helpful as well.
Okay.
Okay, great. So just one question on the chat box, may I request Chris to come in on this? Why not hemiarthroplasty in these trochanteric fractures? Why did you choose to do a total?
I don't think I'd do a hemiarthroplasty in a 63-year-old for a start. And usually when these fail, which we talked about in one of the previous cases, there's damage to the acetabulum. So I would do a total hip, I wouldn't do a hemiarthroplasty.
Yeah, just to add on that, Dr. Abhay, to get your offset and the biomechanics, it is never possible with a bipolar or a hemiarthroplasty, particularly in a failed trochanteric situation. So this gives you a very good option to play with your offset and the biomechanics.
So can we go on to your next case?
Yeah, just a quick recently published article on this non-modular tapered fluted titanium stems, particularly these third generation Wagner stems. They are giving excellent, encouraging patient satisfaction and good results. And the low complication rate and less revision rates with this stems nowadays, it's almost like a go-to revision stem, uncemented distal loading stem. And also the most important thing is the titanium stem allows for gives a good proximal femoral bone regeneration, which is very good. In revision scenario, we need that. And this is the second case. 65-year-old male, 10 years post THR, now has come with an aseptic loosening. He's quite tall patient, and all the workup for the infection is done, and it is now aseptic. It needs revision.
Bez, can you just comment on this one, please?
Yeah, sure. So from my point of view, I think both the acetabular component and the femoral component are loose. You can obviously see there's a bigger femoral defect. So yes, with the workup and everything done, I think both components need revising. In this situation, I have done impaction grafting before, but I haven't done it for the last 8 to 10 years. I would use a cementless cup and I would use a cementless stem. My only concern with the cementless stem is if you look at the diaphysis, I don't think you've got a whole lot of diaphyseal fixed there. So I'd be prepared to possibly even use the locked stem.
Okay. And why is that locked stem, particularly because of the narrow, with the wide femoral canal, you mean to say?
Yeah, absolutely. So if I get a good diaphyseal fix and I've got a decent length of diaphysis and I can obtain a good fit with the femoral stem, fine. But if I'm concerned at all, then I don't want subsident, so I'd think about using a locked stem. Okay. Or I'd have it available.
Yeah.
Okay. Anybody else would differ with what was suggested? Pradeep?
I'll probably use a modular stem. The reasons why I would use a modular stem is if the defect goes down quite low and there's going to be a curvature there. So using a straight stem can be an issue. That's number one. Number two, you said he's a tall guy and there's quite a large defect proximally. So even if you're going to use the area where you're going to probably get a good fit would be quite more proximal where there's still a huge amount of defect. So I would get a good distal fit where the curve is there, and then I'll build it up proximally and adjust to whatever length that I require. That's on the femoral side. On the acetabular side, straightforward revision, I think.
Can we go on with this one, Dr. Raj?
Sorry.
Yeah, please.
This is sort of as Chris's philosophy, this is kind of asking for a distal modular stem. This kind of femoral acetabulum is handmade for quality impaction grafting. I mean, there's no reason why anybody couldn't do quality impaction grafting on this and get away with
asking.
And the issue
asking
here,
for bones.
the issue here really is that, in fact, what you're really trying to do is preserve bone stock in a 65-year-old man, and you don't want to walk into a situation of periprosthetic fractures.
It's asking for bone graft. This is the ideal solution actually for this case, and a normal sized stem really. I would think actually, look at the socket on the second of the smaller x-ray. He's probably had varicose vein surgery, I guess. That doesn't look like bypass surgery, but that socket to me looks fixed. I would check it in theater. I will test it in theater and see whether I like the position and stuff. It looks good enough for me. I wouldn't change the socket if I didn't have to. That as asking for bone graft, normal length stem, nothing unusual. Preserve bone, make new bone. This is waiting for you to come back in 10 years' time. Thank you.
Great. Mez, you have
Bodo,
something to say before we move on to what was done?
Yeah, no, my only comment there is, as I mentioned, I said, 8 to 10 years ago, I probably would have impaction bone grafted. But I agree, there are various ways of doing this. And yeah, in a 65-year-old, you possibly do want to preserve bone. I think it's an art that's being lost, impaction bone grafting, but I think it is a viable option. I probably wouldn't have used that in this case.
Yep.
Great. So if we can
Yes,
go
Dr.
forward
Rajiv.
on this one, Dr. Raj, we have 2 questions in the chat box before we finish.
Okay, last question from Dr. Rajiv. Quick question.
Yeah,
Sorry, I missed
Raj, my
Sir's
question here is that if you see the cup, the head is migrating proximally. So that means that there must have been some amount of damage to the poly. In such a situation, in my opinion, probably the cup also should be revised, not just the femoral stem.
Yes, good. That is a good point. Well taken. Yes, can we move on, Dr. Abhay?
Yeah, sure. We'll take Bodo is itching to make a comment on this. Maybe once you've shown what you did.
I had wanted to, but polyethylene wear of that dimension is actually not really relevant. There's enough plastic left for a few years yet. Just imagine this is a revision operation. You're ripping out a component. The patient is going to bleed. You have to fix the component again. My chief had always a very good question. If the intention was to make the X-ray look better, that's fine. But actually, are you sure you're going to make the patient better? Yeah. That little bit of polyethylene wear, don't forget, we've seen hips going to 50 years with polyethylene wear. That is actually not super significant. I would look at the femoral head, but because the plastic wears is not an issue. If you go back in and do another stem, possibly use a ceramic head or so, you'll reduce that and wear for the next 10, 15 years.
Okay, so this is the immediate post-operative X-ray. And this was done quite a few years back at that time. So this was the first post-operative 1 month later. Any comments here? Yes, Dr. Acharya.
Yeah, actually, looking at the X-rays on the right, you can see that actually there is some increased density on the lateral side. So it looks as if something filling in. Looks as if where you had the greater trochanter osteotomy is on its way to heal as well. Looking at the stem, it subsided. So if you look at where the junction of the taper is in comparison between the 2 X-rays, it looks as if the stem has subsided. So looking at the initial post-op X-ray, you can see that that cortical purchase is very small. The length of cortical fix is quite small, and I would have been concerned about that.
Yep. Okay. So anything you would like to do at this stage, 1 month post-op? Yes, definitely there is some subsidence on the stem side, but anything you would like to do at this stage, or you want to observe?
Yes, I want to rule out infection, etc. again.
No infection. No infection.
Do you have a lateral view?
I have, but I have not posted it here.
There's nothing, no worry about it going to perforate or fracture.
No. Yeah, okay.
Very quickly, can the faculty go through this one? Are they worried about the subsidence? And that's a question in the chat box. How do you control it, and what do you do about it?
The reason for this case was mainly to address this one. So 1 month at this stage.
I think you've got to see if it's associated with thigh pain. And otherwise you can be sitting and watching on this. The thigh pain is the issue.
So
not much of the faculty do something about the subsidence very quickly. If somebody would do anything,
I would watch.
I would watch.
Okay.
Yeah.
Wait and watch. Wait and watch.
Yeah. So there's ample literature.
How is he weight bearing?
The non-modular stems will subside to some extent over a period of 1 year, and sometimes even up to the tune of 5 to 10 millimeters. So we will watch. If all is well, nothing needs to be done. And that's a question in the chat box.
Okay. So
since there is a subsidence within 1 month, probably in my hands, I'll ensure that the patient is not bearing weight or just a toe-touch walking, and observe the patient with monthly X-rays.
Yeah, I think this is basically also again just to show that I think you really do need good distal fit before you actually get the proximal length. So I think the concept of getting a good distal fit is very, very important. And sometimes when you're using non-modular stems, that can be an issue.
Yeah. So that
And
is
you
the
see
point.
the advantage of, sorry.
Please,
The
please go ahead.
advantage of cement. You fix it immediately.
I can understand. Accept it. So the reason for this case is, again, I also mentioned in the history that the patient is quite tall, and this was done few years back, and at that time I like not that commonly we were doing this modular implants. So these were the monoblock stems, and the key point here is we need a longer stems. This is a 265, probably a 300 titanium Wagner stem would have been a better option in this situation. So this is the 8 months post-operative. As Dr. Rajiv mentioned, the weight-bearing part was very much guarded, and slowly I observed him over the period of time. And this is a 2.5, almost 3 years post-operative X-ray. And the patient is now walking without any problem, and the subsidence stopped at that stage where it had at 1 month, and after that it didn't subside, and he's doing well now, comfortable and walking. So this is a case of it went on to heal by that secondary stability, and now he's doing well. So if you look at this paper published in 2011, subsidence. Dr. Rajiv, can you mute them? Okay. So the subsidence of more than 10 mm, 4% to 20% commonly occurred in the first and second generation design. But if you look at this third generation stems, the subsidence part is very, very low. And it is like, if you look at the last line, that is the current study, which is published in 2017, the subsidence is very low. And these stems are really giving very good results. But the only thing is you have to be a little cautious when dealing with some very tall patients and in a complex deformity. A quick one more case.
Can we go forward, Dr. Raj, if it's okay? Because we still have 4 cases to cover.
Okay, right.
One
I will just quickly.
cover.
Okay. This is again a 51-year-old male, 20 years post THR, trivial fall. Patient came with pain. Patient went back and did not turn up for next 5 years. And this is 25 years post THR. Now he came with pain in the right hip. So I had to do the revision. So what I did a modular stem here because of the complex bone loss in the proximal portion. And this is the modular stem which I have used. This is the post-operative X-ray, modular fluted tapered titanium stem. And the advantage with that with this stem is that you have the proximal portion and the distal portion separate, so you can adjust the length, get the distal fixation correct, get good fixation, and then according to the need and the offset and the biomechanics, you can adjust the proximal portion. So modularity is desirable in a complex femoral revisions. It is appropriate to consider this type of stem when we use such a design, and it is in this thing. So this is another example of a modular stem. So advantage with modular stem, it avoids the limb length discrepancy, getting the offset correct, soft tissue balancing, and the biomechanics. And there is very less chance of subsidence, particularly in these kind of complex revisions. But the 3 important points quickly I would like to show here is the stem fracture happens, particularly in a high BMI patients. And when the small diameter, when you're using a small stems, better not to go for a modular stems, and inadequate bony support around the junction. So this is the most important thing you have to take care. And then the intraoperative fractures while introducing the stem and the fretting corrosion at the junction. So tapered fluted modular stems becoming more popular in revision THR, but non-modular stems should not be disregarded as a viable alternative selection, because still that is the go-to stem in a revision scenario. Thank you.
Case. Thank you, Raj. And we'll go forward and take the discussion points further. Mez, can I request you to come in on cemented stems and revision for periprosthetic fractures? There is enough evidence to support their use.
Sure. Thank you, Abhay. Thank you, everyone, the organising committee. So I'm going to spend the next 7 to 8 minutes, just presenting a case and opening up some discussion. So we'll start with the case. So this is a 78-year-old female, had a left cementless total hip replacement 18 years ago. No previous problems with the hip, very well functioning. A few other comorbidities, so hypertensive, has had malignant melanoma in the arm previously, had an olecranon fracture 2 months ago, treated with tension band wiring. So these are her initial x-rays, and we see that there's a cementless total hip replacement. We see that there's some eccentric polyethylene wear of the acetabular liner, and we see that there's a fracture around the femoral component, the cementless femoral component. I'm just going to show you some more images as well. So just some choice cuts of the CT scan, showing the displacement of the fracture, showing the fracture configuration, and just showing you the x-rays. So let's just open it up to people then. So what would people do?
So Shahid sir, can I request you to quickly comment on this one?
Thank you. I would go with the option of osteosynthesis, bone grafting, and cable. But intraoperatively, if the implant is used, I'm going to revise the component. I'll have the inventory of revision of the femoral component. The acetabulum looks good. The lateral view had shown some osteolysis, and that would encourage me to do revision of the femoral component. So if you look at the lateral view, both anteriorly and posteriorly, there is lysis. And if I have to do one procedure, I would revise the femoral component with a diphysial fixation, which could be a modular Wagner or a non-modular Wagner. In my hand, the modular fluted tapered stem works very well.
Very quickly, Chris, would you do something differently? Chris, are you there? Dr. Rajiv, sir?
Yeah, Abhay, I would prefer to fix it up and see that how the patient does, not revising it, Shahid, in the first stage itself.
Okay, go ahead, Miss.
Yeah, for me, it looks like a extended trochanteric osteotomy that the book has already been opened. And I will check intraoperatively the stability. If it is stable, then I agree with Rajiv that we can do bone grafting and cable and maybe a trochanteric grip plate longer.
Yeah, so, okay, so what I haven't shown you guys there is the x-ray of it about 6 months ago, where it wasn't fractured. And actually with being able to compare those x-rays, you can see that the bone around that stem has displaced, and it looks as if the stem has subsided. The stem stayed where it is, but the bone around it has moved. And there's a classification for these various periprosthetic fractures, and this would be termed a reverse clamshell. So the clamshell type of fracture would be in this plane here, and what it does is it sort of divides it divides one part of the bone away from the stem. So I would be suspicious that this stem is loose, and so I'd be thinking of revising it. But just to move on the discussion a little bit, if we're thinking about revision, and it's a talk on revisions, what are people thinking of doing? Are they going to use a modular cemented distally fixed stem? Are they going to use not a modular, a monoblock cemented distally fixed stem, a modular cementless stem? Are you going to use a cemented stem, or are you going to use something else?
Edward, can I quickly get you onto this one before I request Pradeep for a quick reply before we move forward?
A quick reply. He's given us all the alternatives, and it really does depend on your practice. But again, in terms of obviously age and structure, for me, I would be, let's ignore the cup for the answer, and I would be simply removing the stem and getting the bone back into a position. And then I would be cementing a slightly longer stem in very, very good surrounding bone.
Yeah, so Evet, does anything influence your choice of using a cemented stem? You've mentioned a couple of things.
Yeah, well, I mean, you know, obviously the type of periprosthetic fracture and most certainly my reduction. And my reduction would be absolutely key to doing it. And even then I would be able to add bone graft if I had some concern. Even with screws going across, that doesn't faze me. But if I got a good reduction and I felt that the bone was stable, I would be going on with cemented. If not, like you suggested, I would be attacking the diaphysis with some Wagner type stem.
Prof. Noor.
Yeah, I'll have some concern about the poly, because why would an uncemented femoral component have loosening? So if I have to revise, I would actually change the poly to a cross-link poly, have a ceramic head. I would chase the diaphyseal bone with a fluted modular stem, and then with the cable, I'm going to close the proximal bone.
Okay, so lots of thoughts. Let's just move on. So my thoughts were, you know, this is what I wanted to achieve. So I wanted to achieve stable fixation of bone. I wanted to achieve stable fixation of the implant. I wanted the patient to be able to fully weight bear. I wanted longevity of the implant, and I wanted to minimize the risk and complication profile. Those were my aims. So my plan here was to revise the total hip, and you're quite right. I was concerned about the eccentric wear of the liner, and so at the least I was going to change the liner and possibly the cup. I had everything available. I was going to remove the stem through the fracture and gain access to it, as you quite rightly mentioned, an extended trochanteric type osteotomy. And then I was going to, and we've touched on this before, that with cementless stems, there's usually that layer inside the bone, which sometimes is not conducive to a cementless stem or even a cemented stem. So it's really important that you prepare the canal properly, and the fracture gives you access to that. And then my go-to for this, it was a simple type fracture with good quality bone and a good reduction. And if I was able to achieve that, I was going to go for a long cemented stem. So comments. So this is what I did. I did revise the cup.
Yeah. Chris and Pradeep, quickly, can I get you onto this?
Yeah, personally, I mean, I don't use cemented for revisions of stems, but because of the philosophy that, I mean, that's just my personal philosophy, and also from literature, where because of the fact that the impregnation or the integration of the cement into the cancellous bone probably would be less. So I would use something like a conical monoblock stem. It's like an ETO, and I would have just simply used a monoblock conical stem, and that's all that I would have used. Something like a Wagner.
Chris, are you there? May I request Bodo? Would you do something differently, and why?
I'm looking at, this is now the second case where we see actually socket perforation, acetabular perforation. The socket, to me, the polyethylene wear in the soft tissues doesn't go away because we changed the liner. But with these mega sockets, you achieve two things. One, the rim sits out of the socket quite a bit. It pushes the femur lateral, and you have perforated the acetabulum. This is the second X-ray today. The components get massive and bigger. This is, I think, an over-engineered problem. This is modern technique and modern philosophy, I know that, but it worries me. Where'd you go next time? What holes are you going to create next time, and how are you going to fill them up? The socket wasn't the problem. I would have certainly not tackled that, especially when the patient has already the fracture. What I would have done actually is, was the stem loose, by the way? Was the stem loose, Mez?
Yeah, absolutely. Yeah,
was
pulled
loose.
Out by hand. Pulled out by hand.
You know, what we've talked about, two-stage for infection. What I've done occasionally is two-stage for fracture. What you then have actually is an ideal solution to fix the femur, make it heal 2-3 months. That's the one stage, and then you have a proximal intact femur, and you can go for a short component in the proximal femur. This way you have, you know, gone long again. but you haven't gained much. And of course, when you've done the problem on the acetabulum, gone down into the femur, think it differently. Think like fractures heal because Mother Nature heals them. Let the fracture heal, especially when the stem comes out readily. And then you go back normal ways with no much fuss. And the patient has to go through the insult of the fracture plus a massive revision operation. And then we've created another problem, actually the big hole in the acetabulum and the long stem. I would have done it slightly differently. I would have taken the component out, circle arch wired it, see how stable the thing is. If it's stable enough, I would grafted it, keep the patient partial weight bearing or non-weight bearing for 6 weeks or 12 weeks, or you do it in 2 stages. Leave it as a pseudo with a couple of wires around it, let the fracture heal, and then put normal sized small components in. The modern trend of these massive mega prostheses is deadly. You guys are going to create problems for yourselves in 10 years' time when these patients come back and there's no bone left. This is critical.
I'll just make a few comments on that. So you say you haven't achieved anything. I think
you have achieved. Sorry, Mez. Sorry, Mez. It's my frustration about massive and bigger.
Sure.
Sorry.
But no, it's fine. It's absolutely fine. But what I would say is that actually what we have achieved is we've achieved stable fixation. We've achieved stable implant. You've done 1 operation and the patient's been able to weight bear and goes home at 5 days. So actually, I think the achievement is there. Yes, there are different philosophies and I don't argue about that. There are different philosophies, but I think we've achieved quite a lot for this patient. And I'll just share some literature with you with that. So yes, there is some literature out of Exeter looking at in cement revisions for Vancouver type B fractures, and they looked at 23 of these fractures. Hospital stay on average was 11 days, 3 deaths within 6 months, 1 non-union. So we talked about cement extrusion and cement coming out of the fracture site. Not a big problem in causing non-unions. All others united at about 4.5 months, no infections. And then some more recent literature as well, just last year, again, comparing the 2 philosophies. So a long cemented stem versus a long cementless stem, and just some results on that. And it's important to distinguish from this study the 2 groups. So the cementless group was significantly younger with less comorbidities. The ones that had a long cemented stem were older by about 15, 16 years, and also had more comorbidities. Yes, there are controversies, and we've touched on some of these already. Reduction of the fracture. So my philosophy is if I can get the fracture reduced, and there's little or not excessive comminution, then that's a plus. Cement extrusion, again, it's not a problem if you've got a pretty simple fracture. And then with regards to the non-union, certainly from previous studies, it has been shown that actually going long avoids that potential risk of non-unions. So take-home messages, certainly for me, a long cemented stem does have comparable results to long cementless stems in revision for periprosthetic fractures. May give added benefits, allowing immediate weight bearing, decreased risk of subsidence, decreased intraoperative fracture risk, delivering antibiotics locally through the cement, and also may be a cost-effective options. So certainly my practice is that if I've got someone like this, an 87-year-old male, and this is the opposite direction of the fracture to what I presented before, so a clamshell type. Again, the stem is loose, a Vancouver type B in an elderly patient with a simple fracture pattern, and I'm able to achieve good, stable reduction and fixation, then this is what I'd do. Thank you.
Thank you very much. Great case. And we'll move on to the next case. And Darren, may I request you to present your case, please?
Thank you. Good evening, everyone. And congratulations to Prof. Abe and his team for organizing a wonderful webinar, and thank you for having me as part of this event. My name is Darren, and I'm from Singapore General Hospital, and I'll be presenting a case that I think has been already discussed by Raj, but I think nonetheless it's still good to go through the points to reinforce the benefits of cementless revision. There are indeed a lot of benefits using cement, but I think that when one is familiar with one technique that seems to address most of his problems, and he does not deal with revisions on a frequent basis, then perhaps it's better to be good at one thing than to have individual techniques and do them infrequently. So the case I'll be presenting is a 71-year-old lady as of this year. She was 65 at the time of revision. She had a BMI of 23, so not a large patient. Diabetes, hypertension, hyperlipidemia with bilateral arthritis of the hips. And the hip that we will be focusing on is the right hip. She had a right hybrid total hip replacement done in 2006, and these were the post-operative x-rays. I didn't have any preoperative x-rays, but at that point of time, she was reported to have done well. And as you can see, she had some arthritis on the left hip, which subsequently, 8 years later, gave her some problems, and she went for a cementless total hip replacement. She had a hybrid on one side and a cementless on the other side. And from these x-rays, already you can start to see some deficiencies in the cement mantle. There is quite obviously a fracture through the cement mantle, but she wasn't very symptomatic at this time. However, 1 year later, in 2015, she presented with increasing right thigh pain with activity. There wasn't a history of any trauma, and she was otherwise well. So perhaps I could ask the panel what they would do if the patient's symptoms were fairly intrusive. It was quite disabling, and she wanted something to be done. Evaluation such as inflammatory markers were all normal.
Mr. Noor, sir, and then may I request Mr. Smith to come in on this one, please?
Thank you, Darren. I think radiologically and symptomatically, the femoral component with the cement mantle fracture, I would remove it and see there is a possibility of a conservative revision by cement on cement, but
Okay.
I would check and see what the status of distal cement is. If I can remove it without making further damage, I would, but I will have the option of a smaller stem cement on cement revision. Otherwise, a full uncemented or cemented revision of the femoral component. Have a better poly if I can change it to a cross-link poly and have maybe have a ceramic head.
Yes. Well, thanks, Prof. Perhaps maybe I could just further ask you, would the original position, this implant was unfortunately cemented in varus, and there is also a fracture in the cement mantle, or at least what appears to be radiolucencies in the mid shaft of the implant. The implant itself wasn't broken. Would that concern you to do a cement in cement revision with?
I agree with you. So removing the whole stem and getting the femoral component right and avoiding varus would be a better idea. And putting it down the distal tip would correct the varus which was done previously. Take your point.
Would you consider a cementless option? Would anybody consider a cementless option for this case?
Raj, can I request you to come in on this?
Yeah, I would definitely opt for a cementless revision in this situation. See, the 2 points here, one already mentioned about the varus collapse of the stem, and then if you're, hello, yeah. So, so in this situation, if you want to do a revision, I would like to do a small ETO, remove the cement, correct the varus collapse, and then go in for a distal loading stem. distal fixation. The stem length as minimal as possible, but get a good fixation. That will be my choice here.
Can I request Mr. Smith to comment on this, that you have a mantle which appears to be fractured or broken, and in this, would you consider a cement in cement, or what would you do?
Thanks, Abbe. No, I take the point about the various situation. I think you can even challenge this with going with a slightly smaller stem. But the question with regard to the fracture in the cement, that doesn't bother me with cement revisions. I think you can do really classy re-cement in this with absolute ease and get in a slightly shorter stem. And I'm not addressing the cup, but I think this is not a problem for us from the Bristol Exeter approach.
Sorry, could I just pick your brain, because I don't personally do a lot of cement in cement, but I think my personal concern would be that if the cement mantle actually broke, then I'd be worried that one part of the entire cement mantle is actually loosened from the bone or debonded from the bone, and that's why it could fracture. Would that be a possible reason for the fracture?
Yes, it could be, and again, you can put down scopes at the operation, and you can actually go right down to the fracture site, and you can visualize it. And there's no problem with taking out that small amount of proximal medial cement, or carefully going down and taking the cement out to the 50% mark on the lateral. Now you're in a situation where you could actually probably reapproach the cement and take out further cement so that you can get the stem down in a possible position. But I wouldn't be bothered too much about the cement. I think you can re-cement in these situations under any circumstances. And Exeter have shown in their long-term results that this is not a problem.
Bodo, can I quickly get you onto this one? The question about whether you think the cement is debonded and whether you will want to do something differently about it. Mr. Purbach, would you be there?
I'm back on. Can you hear me, Abby?
Yeah, we can.
Yeah. Looking at the cementation, I'd be sort of weary. It doesn't look great, but you can see actually there's a bit of. I don't like cement past the tip of the component. It's one of the reasons why they tend to break. And if they don't break, you get cavitation proximally. The C-stem particularly is designed to, so there's no cement past the tip of the stem, so it can slip into the bone. Possibly that is one of the reasons why the cement broke proximally. You get torque on it, but you also get, it doesn't look great for cementation in my hands. I would certainly try to get all that cement out. For me, the way to do that is, of course, osteotomy on the trochanter allows you access into the canal, take the whole lot out, start over again. And to make better, you can see actually a fairly thin cortex. I would certainly graft this one as well. And when you look at the socket, just when you look at the medial portion of it, that is a socket that I would certainly take out and redo the whole lot of it. I would take both out, start over again, and I would take the cement out. Trochanteric osteotomy will allow you to do that comfortably.
So you would do both these, the femur and the acetabular socket, yes,
yeah,
and because
I would change both.
Ischial osteolysis that you see there.
I would change both, and it's protrusia, Abe. You can see actually she's already, the floor is possibly a millimeter thick, and there's already a bit of a fracture in there. And she's actually, that is not a socket that's well fixed. By the time you take the shell out, you can, take the screws out, that socket comes out quite readily. That's asking for another operation if you don't do it. I would certainly take both components out and I would remove all the cement.
Can we see what you did, Darren? And
okay, so I went into the old approach, which is the posterior approach. I think that was the main approach for most surgeons in the early days in Singapore. I think now the direct anterior is getting more popular. I usually give myself a few minutes to try to remove things from the femur before I move on to trochanteric osteotomy. So usually what I'll do is I'll ask the nurse to start timing. Or give me 5 minutes and I'll start to remove. And if things are moving along, then I will try to remove things endofemorally instead of trying to do a trochanteric osteotomy. Because as much as we've promoted it as being a bone preserving, it makes the surgery much more gentle. But there are complications of trochanteric osteotomy. So if it can be avoided, if I can do everything safely through the top of the femur, I would much prefer to do that. But of course, if I'm struggling to get the cement out, I'm struggling to get the stem out, then I would not really hesitate to do an ETO. I then used a taper fluted femoral stem for reconstruction. I take your point about the acetabulum, but I think in this case, in contrast to all the other cases which revised the acetabulum, I was a bit more conservative. I tested the acetabular shell. It was stable to my testing, and I didn't really want to pull it out because, like what you said, it's already slightly protrusial. And if I remove that shell, I would then know that I'm in for a few more hours trying to reconstruct the socket, and I'd be left with a very big hole. So what I did was that, unfortunately, we didn't have the old liner system available in Singapore at that time. So I just burred the socket and I cemented a new liner inside it. And I used a non-modular taper fluted stem to reconstruct the femur. So thankfully, there was no evidence of any infection intraoperatively, and our cultures did not have any bacterial growth. So this was the final construct. So it's a lot simpler. I think my case is pretty simple compared to what has been shown already. But I used a Wagner stem to bypass the deficient bone proximally to catch purchase. And this is an X-ray taken 4 years out. So it shows probably a millimeter of subsidence, but otherwise her hip pain resolved and her function was restored. So I think that as we heard from all the experts in this panel, a lot of them who are on the cementless side of the house have moved over to taper fluted stems. And I think that in Singapore, we had these two main workhorses for our revision practice. So we had the cylindrical fully coated stems initially. This was available to us much earlier on, and over in the last 10 years, the taper fluted stems was introduced to us as well. Both are available, as we have discussed, either as a monoblock or modular constructs with excellent survivorships in both groups. I think our experience with the modular system was not so rosy because our patients generally are a little bit smaller, and when you have an unsupported modular junction, especially if our junction is very proximal, sometimes they end up fracturing. So at this point of time, we only have, I think, one system that provides a modular system in Singapore. The Wagner stem is different from the cylindrical fully coated stem. It's got a tapered geometry, it's got splines and flutes, and this helps it to achieve its rotational as well as axial rigidity. And it comes in both, as mentioned, both modular and monoblocks. So I think for most of our revision surgeries, especially when we are dealing with cases which don't have much bone loss, we much prefer to use the monoblock because the operation is much simpler. It's almost like a primary fit and fill sort of stem. So it doesn't really take up much time, and it lends itself to a quicker operation, which I think makes a revision surgery a much more pleasant experience. So I think when compared to the old cylindrical fully coated stems, it has much higher success and better reported outcomes in higher grade bone loss. There's a reduction in intraoperative fractures. Patients report less thigh pain, and there's less proximal stress shielding. The topic of subsidence in taper fluted stems is a very important one. It's the main reason for early mechanical failure, instability of the hip joint, and re-revision. And as what Raj mentioned, it's reported at up to 5% subsiding, anywhere from 5 to 10 millimeters in most case series. However, the newer designs like the third generation Wagners, they have increased taper angles, so the angles are a bit more aggressive. They have broader splines to cut into the cortex, and these provide greater axial stability. But in the end, it's important to pre-plan preoperatively to template so that we can avoid undersizing. We can assess where we want to achieve our bony fixation. And one important tip is that when we ream, we look at our reamers as we remove them, and we want to see cortical bone in the teeth of the reamers so that we know that we are biting into cortex, because this is slightly different from the cylindrical full coat technique where we just ream away cancellous bone and scratch fit along the cortex. This one we actually want to be almost intracortical, and we want our splines to cut into the bone. And that's the way that we can reduce the amount of subsidence in these cases. From that, thank you.
Thank you very much, Darren. And before we move on to the last case, which is a different philosophy altogether, one very quick 2 minutes to Pradeep, your take on what is your indication to use a modular stem in a femur defect for the benefit of the house? And Dr. Raj, very quickly, what is the indication to use a non-modular stem in a femur defect? Very quickly, 2 minutes each, please. Pradeep, can I start with you?
Yeah, so one situation in revision is when your defect goes quite distal, almost to the middle of the femur, then don't think I would be able to get a good hold, or I would compromise on my hold proximally because of the diameter and the tapering of the stem. And so for getting a good hold distally, and also because there's a curvature of the femur, though I know that a lot of the non-modular systems, even though it's straight because it's tapered, can accommodate to some extent, I believe it's better to use a good fitting stem with a modular stem distally and then make it up proximally. So it's mainly when the defect goes down very low, that's when I would use a modular stem. The second situation when I would use it is when there is a big defect, or when the proximal part of the femur is all mush and it's very difficult to judge the soft tissue distance. And so when you have issues with soft tissue balancing, where especially when the proximal femur is very comminuted, then again, I would use a modular stem.
Great, thanks. So 3A, 3Bs, femurs, and when you're especially wanting to play with your biomechanical reconstruction proximally is when you will use a modular stem.
Yeah.
And would you use a non-modular stem in most other situations?
In most other situations, a conical non-modular stem like the Wagner is what I would use.
Great, thank you, Pradeep. Great points. Raj, Dr. Raj, quickly on to what is your indication for a modular stem in femur defects?
In a modular stem or a non-modular?
When will you use a non-modular stem for femur defects?
Okay, in non-modular, almost always try to go for a non-modular stem. A monoblock stem is distal loading. Titanium fluted stem is always. But as you mentioned, a type 3B stem, a long, tall patient, a type 3B femoral bone loss, where the isthmus is also quite wide. Then we also proximal bone loss is very severe and complex in situation. Then I will go think about a non-modular stem. Templating is very, very important here. You have to measure the length, measure the stem available, sizes available. Based on that, your non-modular option should be prepared. You have to be prepared. Otherwise, most of the time you can get away with your non-modular stems.
Okay, great points. Thank you, Raj. Can I request Dr. Rajiv sir for his last and final case before we have the final take-home talk on algorithm of choice of stems? Dr. Rajiv sir.
I think Dr. Rajiv you're muted. Dr. Rajiv, you're muted.
Rajiv sir, we can't hear you.
He's mute.
Yes, can you hear me now?
Yes, sir, we can.
So, sorry, yeah. So we had a wonderful discussion on very difficult subject, and I'll be discussing now a few cases where the different philosophy has been used. The first case that I wish to discuss here is this patient, 57-year-old with a dysplastic hip. Can I ask the faculty what would be their choice? It looks like not so difficult a case
Professor
in
Shahid,
the present situation.
May I request Dr. Shahid sir?
Yes. So there are challenges on the acetabular side and the femoral side, and I would check clinically about how much I would be able to, and I would do a CT scan to assess the bone on the acetabular side. And I might be able to use a simple primary femoral component and I would do soft tissue release, and I would have the option of doing subtrochanteric osteotomy to bring the femur down. So first soft tissue release, bringing the femur down, but if I have a problem, I would have little hesitation in doing subtrochanteric osteotomy, shortening, and use a modular type of implant. Astrom type of implant works very well, where you can get a diphyseal fixation, proximal fixation with metaphyseal sleeve, and you can change your version and offset.
Very right, Shahid. And I think that I've put this case here mainly to show that subtrochanteric osteotomy is so much needed in these cases where the head is operated and it is very rigid fixation, rigidity because of the long-standing issues. Abhay, can I ask the faculty from UK, Dr. Bodo and Dr. Chris,
Yeah.
what would be their choice in such a situation? Bodo, are you? Will you be there?
I'm here. Yeah. So I haven't ever done subtrochanteric shortening. I don't do that. I take the trochanter off, and often enough, you find actually you can, when you look at the musculature, look at the abductors, and you can see medius and minimus on the X-ray. It's almost wrinkled up. So, I've found that actually it's not often a problem to bring the trochanter down, even with the osteotomy. What happens is you can actually dial it in, it's almost like on the clock face, when you need to augment the acetabulum quite clearly. There's a dysplastic hip, solid graft to the acetabulum to make a socket out of it. You will probably need what we call a padded skid, a shoehorn, to bring the hip in, but only once or twice. I wouldn't consider shortening the femur. I would do the osteotomy and the neck cut, and I would expect to get that in. It will need solid grafting. I've done a case like that on Tuesday. This is sort of, yes, a little bit more effort to mobilize the hip. It's an interesting constellation. If you look at it, you can see she's got a double articulation. She's articulating on the lesser trochanter as well. That's a fascinating pattern. She has two articulation surfaces. So yes, bone graft, need to have bone from the bone bank. Her formulate isn't good for anything. Trochanteric osteotomy, solid graft to acetabulum, probably a 38 socket. You may even have to shorten it, make it a bit smaller. I've been to Bangor once to customize even a 38 socket to something smaller. And I would expect you will have to have an Asian size stem. I would certainly cement that as small as that femur is. By the time you look at these non-cemented components and you whack them in, there's always a danger of breaking something. And of course, then you can position the component where you want to.
So would you prefer to bring the head down to its anatomical position, or would you accept a high placed cup?
The forces on that socket are going to be enormous if you leave the femur standing next to the pelvis. You need to bring it down to stabilize the hip joint. You have no hesitation to bring it down. And I don't think that's going to be a problem. For length, that is not that far off. What you need to worry about, of course, is the femoral nerve. And you may have to think about, supporting that leg in flexion at the end of the procedure, but I wouldn't hesitate. The hip I've done on Tuesday didn't look much different to this one. The hip on Tuesday was probably a bit even stiffer than that one, closer to the acetabulum with less space to get in. No hesitation to do it with a routine technique.
Can we go ahead on this one, sir?
Thank you, Bodo. I think we'll have your more comments on the next X-ray. Now, that's how the patient comes to us. The patient is having the shattered proximal femur. The surgeon has tried to bring down the head to the anatomical level. In fact, a little lower down. And the proximal femur is all shattered.
And you can see why, because of course, now the patient's got the trochanteric osteotomy they would have started with. In the end up, we get to the solution because that's what Mother Nature wants it to be. Now, the problem is the non-cemented component, both on the acetabulum and on the femur, because you have no way to do anything. Non-cemented means oversized every single time. And that's the big criticism I have of this thing. Actually, the fixation is achieved. It's called non-cemented or cementless or any fancy name. What it actually means, it's an oversized component hammered into bone. When you have such a small skeleton, you haven't got much space for anything. and then you hammer it in on top of things. I think that's critical and crucial. Look at the acetabulum that sits out at least 5 to 7 millimeters. The cemented component wouldn't do that. It would sit inside the confines of the acetabulum that you create. The femoral component, of course, because you're non-cemented, sits out so proud that it can't go anywhere.
Yes,
Start
I
over
think
again. Yeah,
Yes,
it proves Charlie's point, every bit of it. The osteotomy to get in, the size of components and the way to fix them, and the variability that you have as a surgeon to play with that as you go along in the procedure. Charlie's philosophy would have done very nicely in that hip joint without having to get through that complication yet.
Right. So my comment here to the audience is, our younger colleagues, that where you are not able to reduce the head and bring down the head, the subtrochanteric osteotomy is a far better way than just trying to hammer in the femoral stem. Now, in this patient, there was further education that this patient was coupled with the infection. So now the situation changes. Bodo, would you like to go ahead with the one stage in such a situation, or would you accept the two stage revision in such a situation?
I would still do a one stage. The goal of one stage for deep infection is clearing out the bleeding. Then remove the components. They need to come out anyway. By the time you got a cavity, if you did it in two stages, you would leave that cavity behind. Use cement allows you to give extra antibiotics at the same time that you fix the components. If you did end up with another infection, that's no worse than a failed first stage from a two-stage procedure. And they are extremely rare. Our data at Writing now for the last 4 decades supported doing it in one go if you can. Save the patient another painful experience. Do it in one. The gold standard must be one operation for a patient, not 5.
Shahid, would you prefer another approach in such a situation?
I would not be so courageous to do one stage. As I've said in the beginning, that to deal with one stage, you need to have a team like a tumor board. So you need to have an ID person experienced in dealing with musculoskeletal infection. But I would do it in stages, step by step. Eradication of infection is the first step, and reconstruction is the second stage. So I would remove the implant, I would put a cement spacer, eradicate infection, and then plan again. But that reinstate that what I've said in the beginning, subtrochanteric osteotomy shortening would have resolved such issue, templating would have resolved issue. And I agree with Bodo that the primary surgeon did not anticipate and did not prepare with a smaller size cup availability. So failing to plan is planning to fail. So these are difficult cases. And the comment for the audience is that you must understand what is simple, what is complex, what is challenging. And then for challenging cases, you need to be prepared, your skill and equipment.
Right. And one comment here is that for the audience, that the cup placement, you should not be too enthusiastic to bring down the cup too much, like in this situation. And the infection, I agree with you, Shahid, that it needed in our hands, probably, Bodo, we prefer the 2-stage in such a situation, basically for the reason of the cost of the implant and the general condition of the patient, because sometimes these patients are not as strong. Their immunity status is not as strong. So in some cases, we prefer that. But mostly in our situation, we prefer the gold standard of 2-stage revision in infection. So now the question is for the faculty, what would you prefer now? Once you have cured the infection, what kind of an implant would you like to place here? What will be the 2nd-stage revision implant?
Can I request
would you
Mr.
like
Smith
to tell
to
us
come in on
on
this?
Your thoughts?
I would, once you've done, actually, I think I would have tried to do it in one with cement. You can do it in the 2nd stage as well. At this point, with the cavity, with the acetabulum exposed, I would graft it. in a second stage from that, I would graft this, would bone graft the acetabulum to make good on the defect. That to me is probably only a 38 size socket and a normal cemented component, proximal femur, proximal fit. We've got the C-stem comes with a slightly longer version. If the proximal femur doesn't look great, you can do that, but I would probably graft that, try and put some bone back into it, make the proximal femur conform again. Mother Nature is quite wonderful. What I've shown you actually is happening automatically. It's not because we make the body like that. It's because the body chooses to have that shape and form. And there's always a tendency to get back to that for function. That is, when we talk about trabecular metal, that's wrong. That's poor terminology. That's again a euphemism. Metal can be porous and the same size that bone is, but the structure in bone, the trabeculae, they follow function. Bone grafting will allow you to do that in part. It's not like planting seeds, but you can achieve quite a bit with that. At that stage, bone grafting, normal sized components.
Any view of the faculty on the use of the bone graft in such a situation?
So can we move on? We're almost quarter to 10 on this.
Okay.
So I think whenever we are constructing, we would do bone grafting, but a scratch fit cup, host contact would do well.
Okay, so we went ahead in this situation because we found that the bone in this area is not enough, and it was difficult to fill it up with the bone graft. So we opted for the tumor prosthesis, and that's what this patient is. As you see, that's at 3 months, and that's the patient taking the stairs at 3 months, at 5 years, and that's what the patient doing. A quick, Abhay, can I just show quickly?
Yeah, so
one
maybe
more?
just a very quick case, sir.
Very quick case,
we
yeah.
have a lot of
Okay,
time.
so I'll just move on fast.
Yeah.
This is
Maybe
the patient
you
who
can
had
go through the
the,
entire case and then maybe one finishing
Right.
comment. by
Very
faculty.
right, yes. So this patient had the multi-level, as you can see on the lateral view, the whole of the femur was involved. And in this case, the total femoral replacement prosthesis was used, as we can see it here. The femoral vessels and nerves were all saved. And that's what you see the patient at 2 weeks and patient at 5 years. Now, a quick mention here that the patient is doing well at 5 years, but that's not enough because when we see this patient another few months, that the patient had a dislocation, and the reason of this dislocation was the broken ring, and that's what this patient had. The whole revision was done, and using change the ring as well as the femoral head. That's what this patient was. My last 2 slides, that infection in a tumor prosthesis is very important, and one has to be careful because a long operating time and patient's immunosuppression in case of the cancer. Infections most often present within 2 years postoperatively, and 70% of the postoperative deep infections are presenting within first year of the surgery. I'll avoid any more.
So maybe just two quick comments by Dr. Darren and Dr. Pradeep before we move on to the last talk of the day. Darren, would you just come in, please? Your take on indications for tumor prosthesis?
Yeah, I think that you'd have to be very careful when we decide on tumor prosthesis. I think we usually use it very sparingly, but when we deal with massive bone loss and we don't have the ability to reconstitute the tube, then I think that's a very useful implant because it really can get the patient up and about again.
Okay, thanks. Pradeep, anything to add here?
Nothing much to add, but I mean, other than to say that sometimes this is probably another situation where infection bone grafting is probably also useful for getting good fixation distally.
Great. Thank you. For paucity of time, we'll, with your permission, sir, can we move forward, Dr. Rajiv?
Thank you so much.
Okay, so may I request Dr. Everett, Mr. Everett Smith to present the final take home for the day, which is algorithm for choice of femur stems. We can't hear you, Mr. Smith, but you're not audible.
I think, yeah.
Yeah.
Thank you.
Yeah.
Thank
Great,
you.
thanks.
I'm going to focus on the primary situation. And what I've heard today is many, many different philosophies, many ways to skin a cat, not necessarily all incorrect and not necessarily correct. And I think there's some take-home messages in understanding what you've got to do. I do have algorithms for revisions, but today I would just like to review the primary situation. How do I move the slide on? So my disclosure is that I have issues relating to Stryker and the charity. I'd like to thank Abhay and Rajiv and all the faculty for a fantastic afternoon or evening, depending where you are. This is where we are in Bristol. There has been a surge mentioned by Chris, and this has been driven by coronavirus in the UK. And we all know what we're facing, which is an increase in primary and revision hip replacements in an aged population with different lifestyles. And this has been brought out by the faculty with all the cases that we've seen. And of course, the challenges are some people are dealing with significant bone loss and therefore having to deal with a far different situation than simply doing impaction grafting for a variant primary situation. There have been terrible design disasters over time. The most recent of these has been the ASR with a 13% failure rate at 5 years. And the question, and this goes to the revision situation, is when is it safe to adopt a new technology? The failure points we've discussed throughout this lovely meeting, and the modes of failure, most importantly, alter over time. And they are, of course, multifactorial. We can look at a wonderful design like the cemented Stanmore implant, having a 73% survival at 20 years. There would be regarded as a challenge if some issues with regard to offsets, etc., and the type of polyethylene we used, but those are fantastic results. The registries are an important review to go to when you choose your hip device. And the Swedish, the longest joint registry, does split up the difference between the Exeter matte and the Exeter polished. So you have to be very careful when you choose your stem in these situations. And you will all now know that the registries, other than the Swedish registry, have excluded the Exeter matte stem in the analysis of the survival of this brand. Well, cementing technique, we've heard a lot from Wrightington, and this is certainly a challenge. Can we improve on the Charnley approach to a hip replacement? More interestingly, I believe that cement technique has improved over time, particularly the washing and lavaging of the canal, which actually aids in the longevity of the hip replacement. More recently, in the BJJ, Bloch suggested that there is a superior survival for all cemented THAs in all ages. We've also mentioned the door approach to a classification of the femoral stem, and you have a stovepipe femur more likely to be present in the elderly patient, and this suggests you should be going towards a cemented stem. Of course, the caveat is all over the world, the cementing technique has been lost, and there are few people now doing cement techniques properly. The SHA suggests that overall, a stem is less likely to be revised if cemented. There is a reduced periprosthetic fracture, but surprisingly, as we've heard many approaches to different situations, there is a massive increase in the hybrid hip replacement, reversed hybrid in Sweden. And this is because of the tendency to go towards cementless stems. You must also look towards implant rating, and the ODEP or the Orthopedic Data Evaluation Panel, was initiated in 2003, which gives you another guideline to what stem you should be utilizing in your armamentarium. And it gives different levels of evidence of survival, as a 10A star being a 95% survival rate. If you have a look at this slide, you could get 3 scenarios of 3 different stems with different survivals at 10 years and 7 years. And I would put it to all of those out there, which would you be choosing and which implant is in fact the best? Cemented stems overall, we now know, are less likely to be revised in the elderly patient over 75 years old. But as in this discussion today, there are anomalies throughout, and there are anomalies throughout the registries. As a quote, despite the enormous amount of data, there are drawbacks with registries, and they don't replace prospective randomized trials. One is unable to discriminate between the individual cup and stem components in the analysis of the cause of revision. And of course, we know that there are no clinical and radiological investigations or informations available to the registry when they provide us their data. In a recent meta-analysis in 2013, it was suggested that there now is no superiority for one type of fixation against another. Of course, the supreme challenge for us all is the younger patient, one who's more active and has got a longer life ahead of them. We do know that from registries, the less than 55-year-old has a reduced survival as compared with any of the other age groups. And you can have a look at this at the 10-year survival for males and females, most worse in the females. There's a changing use of fixation, there is no doubt. And the UK can identify that we are going towards the uncemented or cementous hip device. Even the Swedes are turning towards cementous implants. If you look at the recent report from the Australian registry, in essence, this slide suggests that there is no difference at 15 to 17 years between the outcome of a hybrid situation, a cemented or a cementless stem component. Here is our problem, and we've debated it all day. You have wear, and polyethylene, of course, has changed, but you have to take cognizance of both the acetabular and femoral design as well as the fixation. Your stem choice is affected by numerous factors, as noted in this slide. And fixation and articular bearing surface in cementless stems has also changed. And it is no doubt that the more popular head now throughout the world is the size 36 femoral head. Now, modular necks have been reviewed, and particularly in 2017, we were quite clear that fixed neck stem survival is better for any bearing surface. We hinted at trunnion wear, and Chris actually discussed the issue of putting on a sleeve in a revision situation. And you can see in this trunnion of the 12-14 tape of a pinnacle Karai system that there is wear in the larger head. It is much better, obviously, when you utilize a femoral head, but I put to the faculty and all the delegates out there, but more important is the length of the taper spigot that you deal with. If you have a longer taper spigot, you have less problems, and therefore you can return to utilizing a large ceramic head without a sleeve. Stems by fixation really do show, when you look at the recent registry, that there is very little difference between a cemented, cementless, and hybrid stem. Cross-linked polyethylene has been a big jump in terms of making your match between your cross-linked polyethylene and ceramic head. And we've all gone this way, I believe. The Swedish hip registry has fewer numbers than the UK registry. It is a conservative registry, much like the Wrightington philosophy and the Exeter philosophy, but we do know that the implant problems will not be evident in the early years, but will come on after 5 to 10 years. And data again suggests, slowly but surely, the uncemented stems may be preferable in men under 50 years old, notwithstanding what they say in Wrightington. Critical factors in cementless stems are stem sizing in relation to the femoral canal. You have to gain the initial instability. And as Podo says, You then have other problems that you've bought into if you don't use a cemented stem. You have the issues of fracture, offset abductor function, leg length, and in some cases, you still get thigh pain. Surface coating is different in every one of your stems, whether it be a revision and a primary situation, and choose your stems wisely. These are slides to suggest that actually there are excellent cementless stems, both in the primary and we know in the revision hip situation, such as the Spatorno, the Furlong, and the Zweimüller, which has been going since 1979 in over 500,000 patients with a 98% survival at 15 years. What was surprising in the recent ODEP evaluations and the beyond compliance evaluation was the stubbies or the mini stems. And these cementless mini stems are now showing better results than we believed was ever possible. The 10-year survival rate shows that stubbies are better than standard femoral stems, and the mini stems have a reduced revision rate. There is a problem, and the caveat again is the increased cumulative evidence of fracture and loosening for procedures using stubbies compared with the normal femoral stems at 1 year. And remember that the numbers are still very, very small within the registries. If you're looking at cost and qualities within your department, and we have to do this all the time, if you're going to go on Pennington's paper, which does have some limitation in terms of the patient age choice, the quality and outcome in cost is better for a hybrid as compared with the cementless and cemented stem. And probably from a cost basis is the most effective hip. Well, how do you decide? We've been doing it all through this Indian arthroplasty discussion. Implant survival, look to the registries, and the registries are now bringing in revision data. The ease of use and replication and habit is key, both in the primary and revision situation. And if you are choosing a new device with yourself or within the department, monitor and audit it carefully, and don't flit from different design to different design. Follow through a design until you become skilled at it. And your surgical practice, of course, impacts on what you do. And just like we heard Chris is a person who obsesses about precision, and he uses robots. That will make an effect. Who scrubs for you makes an effect. Who are your assistants? Are they senior surgeons or aren't they? And your desire to perform MIS has a big impact on the implants that you choose. And that hip device can influence the survival. And your decisions are affected, of course, by tradition, where have you trained, like I trained in Cape Town, and your personal bias. I say to the faculty and the delegates, progress is impossible without change, and those who cannot change their minds cannot change anything. Thank you very much for having me here today.
Thank you, Chris. Everett, what a brilliant summing up of all the principles, and I'm sure they hold good as much for revisions as they do for primaries. So without spending and more time on the event, can I pass on the baton to Dr. Rajiv sir for summing it up? And I think we should call it a day now. We've spent 2.5 hours discussing a very important topic.
Thank you, Abhay, and thank you, Everett, for summarizing it so well for all of us. These are the webinars which are placed on our association website, and our members can view these specific issues as the time comes, whenever they need. So these deliberations, these discussions will be very useful for our association and for improving the knowledge and sharing the knowledge between us. Thanks very much, Abhay, for organizing such a wonderful webinar. Thanks to the faculty from various places, especially Chris from Australia. I know it's very late over there. Thank you so much for everyone. And let me announce before we close, our next program is IAA WIROC Global, which is going to be part of the WIROC meeting on 24th of March. So I would suggest to our members that please note this date, and also the April 21st, when we are discussing a very important discussion on the performing a well-done total knee arthroplasty and minimizing unhappy knees which is organized by our friend from Bhubaneswar, Dr. Devvrata Padhi. And I think this webinar will also attract a lot of attention of our members. And lastly, I'll just say that encourage your colleagues to become the member of Indian Arthroplasty Association by just going to our association website or write to us, me or Dr. Rajkumar, Secretary of Indian Arthroplasty Association. Will be happy to support you in any way. Thank you so much, everyone. It was wonderful discussing with you on very, very interesting topics, very lucid presentations. Thanks so much.